Good day, everyone, for day 2 of this international webinar on the long-term social impacts of the COVID-19 pandemic. Just to allow a few latecomers to come in, I thought I would maybe just give my own impressions about day 1. So we had some interesting talks and also some interesting connections. So this is, of course, a personal view. So Professor Dominique Abrams, he was the first keynote speaker and in a sense set the tone for the webinar, I think. He was the lead author for the British Academy's study on the COVID decade. And he talked about various things like inequality, the trust deficit, community engagement, and also education. So on the inequality thing, I thought it was interesting that, Professor Malhotra from India talked about some of the existing measures for social protection that perhaps, went some way to reducing the inequality. Although what he was saying is that it is difficult to measure inequality in the short term. On the trust deficit, it was interesting once again that one of our lead speakers, Professor Mukherjee, talked about creeping authoritarianism in Indian politics. So his view was a bit different to Professor Malhotra's, but that was interesting contrast in perspectives. On the community side, we had a presentation later on in the day from Kashmir, Dr. Mehak, I think if I got her name correctly, also talking about communities that were resilient, even though they were fragile in Kashmir. But that could be contrasted with a talk we had a little after that from Kabul, another fragile community that did not do well during the pandemic. So there were some interesting connections and linkages. For me, a very sort of poignant remark was made, I think, by Professor Mukherjee, who commented that during the second wave of COVID in India, when the numbers increased drastically, he said that India achieved a classless society in the sense that rich, poor, Hindu, Muslim, whatever, they all lost people due to COVID. So it's a very sad thing. So it left me wondering whether we tend to be united in adversity, but divided in prosperity. Anyway, these are some of my own personal thoughts. Let's get on to the webinar on day 2. Today's webinar, in the first part, we'll focus on health and medical issues. We have 2 keynote speakers on that. And then after that, the lead speakers will talk mostly about cultural aspects, and that will continue for the thematic talks as well. So let me introduce a guest who has very kindly consented to give a message to us on day 2. He is Dr. Palita Abekon, who is a senior physician and public health professional from Sri Lanka, with postgraduate education and training from the universities of Geneva and Southern California and the Harvard School of Public Health. Dr. Abekon chairs the National Authority on Tobacco and Alcohol, serves on the National Advisory Committee on Communicable Diseases, and is a member of the National Medicines Authority of Sri Lanka. He is a former president of the Sri Lanka Medical Association, and he serves as a member of the WHO Global Learning Academy and as one of the WHO Secretary General's Special Envoys on COVID-19 preparedness and response. So that was the main reason we asked him to deliver this message. He is the recipient of the Dr. Fred Katz Award of the Australian and New Zealand Association of Medical Education, the Lifetime Achievement Award from the Southeast Asia Public Health Education Network, and most recently, the Cassiu McLaren Leadership Achievement Award of the Asia Pacific Academic Consortium for Public Health. Dr. Abekon, I see, has joined online, but he has sent us a recording of his message, which we will now play for you.
Professor Priyan Dias, President of the National Academy, members of the Academy, ladies and gentlemen. It is an honor for me to be invited to share a few thoughts at this very important and very timely webinar. And I thank Professor Preparedness for this privilege. I will share some reflections mainly in my capacity as one of the WHO Director General's envoys for COVID-19, and having had the benefit of a ringside view of some of the COVID-19 developments in the past 2 years. I will briefly touch on 3 aspects of the pandemic. A few words about the health and socio-economic devastation resulting from the pandemic. Words about the transition from the acute pandemic response to a sustained control stage. And a few words on what global governance is needed for this COVID decade. We have been struggling to emerge from a defining health crisis of our time. We have grief for those we have lost due to COVID. We empathize with those who lost their livelihoods. We have concern for the children who miss schooling and their childhood, and much more. COVID-19 has had significant, inequitable, and unfair impacts depending on where people live, their level of education, socioeconomic, and health status. It has exposed the injustices and contradictions around us. It has highlighted our strengths and our vulnerabilities. And we have seen what is possible with cooperation and seen what we risk without it. Who would have thought 2 years ago that shops, restaurants, schools, and workplaces would be closed for so long, that global travel would grind to a halt, that even simple shaking of hands could be life-threatening. Words like physical distancing, contact tracing, and reproduction number have now become common parlance. But there are some serious questions here. How do you practice physical distancing in crowded living conditions? How do you stay at home and also feed your family? How do you practice hand hygiene when you lack clean water? Thus, we see that the COVID-19 pandemic has had significant, inequitable, and unfair effects depending on where people live, their level of education, their socioeconomic and health status. It has aggravated the negative health outcomes for those who are already disadvantaged in society. As the WHO Director General Special Envoys for COVID-19, we have repeatedly called on the world's leaders to jointly address this issue. Access to essential health services should be available to everybody. This is the right to health. Yet, we have seen a continuing lack of solidarity which has accentuated this unfairness. We are mired in a 2-track pandemic, one for the rich countries and the second track for the poorer countries. So Gordon Brown, WHO Ambassador for COVAX, has noted that some countries, such as the Democratic Republic of the Congo, had vaccinated fewer than 1% of their population. Some others have been able to vaccinate less than 5% of their population. And death and severe disease continue to ravage their social and healthcare systems. There are now over 80 countries which did not reach the global target of vaccinating 40% of their populations by the end of 2021. The world is not going to reach the global target of 70% vaccination by June this year either. In contrast, the rich countries have already administered the 3rd and even 4th doses of the vaccine and have coverages well above 80%. Next, maybe a few words on the topic of COVID-19 from the pandemic status to a sustained control. Many are asking, could we have ended the pandemic earlier? Where are we headed? Where will it end? The answer is simple. It will end when we choose to end it. 2 years ago, when COVID-19 was declared a pandemic, we never imagined that we will be asking these questions now as we enter the 3rd year of the pandemic. Nevertheless, now with rising population immunity and with the highly transmissible Omicron variant, the world needs to prepare to shift from the acute response phase to a sustained control phase. What is the WHO's concept of transition from an acute pandemic response to sustained control? There are two guiding principles for a shift from acute response to sustained control. One is reducing and controlling the incidence of COVID-19 infections. This should focus on protecting vulnerable individuals from exposure and reducing the risk of future variants. Two, preventing, diagnosing, and treating COVID-19 cases. This should target reducing morbidity and mortality and long-term consequences of these infections. Also, fine-tuning our surveillance systems for early detection, investigation, and assessing the impact of the variants that can arise. What then are the likely scenarios for COVID-19? With the evidence that we have, we could foresee at least 4 scenarios for the rest of this pandemic. This will, of course, overlap in different locations and in time. The first scenario is that the COVID-19 transmission reduces significantly and the pandemic becomes endemic with occasional flare-ups in under and unprotected populations. Second scenario would be that the pandemic takes on a seasonal pattern like a flu with updates of vaccine composition being required periodically. Third scenario, in this there is further virus evolution, more fit variants of concern, and more immune escape, and the pandemic will continue for a longer time. The fourth and the last scenario we envisage is that there is significant virus evolution that continues rendering countermeasures ineffective or difficult to control for a long time. Experts now believe that the virus will never go away completely and instead will continue to evolve to create new waves of infection. What then would be the strategic priorities for this shift? End of the acute phase means achieving the target to vaccinate at least 70% of the population of every country with a focus on the most at-risk groups. It means reducing mortality through strong clinical management, beginning with primary health care and equitable access to diagnostics and medicines and antivirals at the point of care. It means boosting testing and sequencing globally to track the virus closely. It means the ability to efficiently calibrate the use of public health and social measures whenever they are needed. It means restoring and sustaining essential health services and looking after the health workforce. It means engaging and empowering communities, sustained financing with a constant focus on equity. And finally, it means that countries will require to build sustainable systems for integrated respiratory disease control. It is for us dangerous to assume that Omicron will be the last variant or that we are in the end game. Each country is in a unique situation and must chart its own way out of the acute phase of the pandemic. For this, the countries will need the technical support of WHO for some time. This brings me to my final point, which is, in the aftermath of COVID-19, what do we think are the priorities for international governance for health security? We need to strongly support the development of the legally binding pandemic treaty and a global health emergency architecture that the WHO Director General is spearheading now. This will be a landmark development for a safer and healthier future for all mankind. We need a WHO with more authority and sustained financial resources to direct health emergency preparedness and response, and to move medical supplies and resources to every country where they are most needed. The world should not experience another vaccine nationalism that will cause health inequity. With a WHO with a capacity to manage outbreaks and novel pathogen control in a holistic, sustained manner, we would find the world to be a secure place. And then building back better will have real meaning. We are at a critical juncture as we enter the third year of the COVID-19 pandemic. is also the midpoint of the 2030 agenda for SDGs. We can and we must turn the pandemic into a window of opportunity to search for a fairer, healthier, and sustainable future. In Southeast Asia and in Sri Lanka in particular, we have much to be thankful for. Yet, there is a sobering reality of gaps and inequities in our health and social systems coming into sharp focus during the pandemic. We must learn our lessons and apply proven solutions based on science and evidence to build back better towards our twin goals of health security and universal health coverage, which should be based on primary health care. High-level, esteemed academic bodies like the National Academy, with the best brains and the rich experience in the country, you should be in the vanguard of advocacy for this transformation. Let me now end with a recent quotation from the WHO Director General, Tedros Adhanom Ghebreyesus, who says, "Courageous and compassionate leadership, fidelity to science, generosity in sharing the fruits of research, and an unshakable commitment to equity and solidarity to tame COVID-19, how can we hope to prevent history repeating itself?" Unquote. Thank you very much, ladies and gentlemen.
Thank you. Thank you, Dr. Bikot. I'm sure Professor Malik Perez and Professor Ann Mills will pick up on some of those pointers that you made in your presentation. However, to preside over their presentations, it is now my pleasant duty to introduce our chair, and that is Professor Nadira Karunavira, who is the Chair and Senior Professor of Parasitology at the Faculty of Medicine, University of Colombo, and an honorary visiting fellow at the School of Public Health at Harvard University. She is a fellow of the Third World Academy of Sciences and an honorary member of the American Academy of Arts and Sciences. She is also the current Vice President and President-elect of our own National Academy of Sciences of Sri Lanka. So over to you, Nadira.
Thank you, Priyan. It is indeed an honor and a privilege that I get to chair this session. There are two very eminent speakers, and let me introduce you to the first speaker. And before doing that, just to remind you that these keynote presentations will be for 30 minutes, and after that, there's a 15 minutes question and answer session. So please, the participants, please type in your questions in Q&A if it is accessible to you. If not, please use the chat box. We will give priority to Q&A, but if you are unable to access it, please type in your questions in the chat box as well. Thank you. So let me move on to the first speaker. It is an absolute honor that I get to introduce Professor Malik Perez, who is going to be the first speaker. Professor Malik Perez is the chair of virology at the School of Public Health, the University of Hong Kong. He's originally from Sri Lanka, and we are so proud of him. He co-directs the WHO H5 reference laboratory and the WHO SARS-CoV-2 reference laboratory at the University of Hong Kong. Currently, he serves as a member of the WHO International Health Regulations Emergency Committee on COVID-19. He is a clinical and public health virologist with a particular interest in emerging viral diseases at the animal-human interface, and he uses a One Health approach in his studies. Professor Perez has over 800 peer-reviewed research publications in international scientific journals, which have been cited for over 76,000 times. In recognition of his research contributions, he was elected a Fellow of the Royal Society of London, and he was also recently jointly awarded the Future Science Prize in Life Sciences for contributions in pathological discoveries in severe acute respiratory syndrome, or SARS, you might remember, and its zoonotic origin, which of course had implications on combating COVID-19. Professor Perez had his undergraduate medical education in Sri Lanka, that was then Ceylon, followed by postgraduate training in virology at the University of Oxford, UK. I also should add he's a fellow of the National Academy of Sciences of Sri Lanka as well. Without further ado, let me invite Professor Perez to make his presentation. Over to you, sir.
Thank you very much, Nadira. Can you hear me okay?
Yes, very clear.
And thank you for this invitation to join your webinar, which in fact I joined yesterday as well. Very interesting discussion. So if I can share my slides.
It is on and you can make it full screen. Yes, now it's on.
Yeah, right. Okay. So I actually want to pick up on Dr. Palita Vekun's last point when he talked about building back better and health security for the future, but learning from the lessons of the COVID-19 pandemic. And you can see that I've put the title as Lessons for Global Security. And I've put health within inverted commas because I think the COVID-19 pandemic has taught us that health security is global security. I mean, we heard yesterday about the impact of the pandemic on the economies, $3 trillion lost just in 2020, and so many other major impacts which were covered by Dr. Gunithilake yesterday. Right, so what I will try to do in the next 30 minutes or so is to address the question, why do we, because as Palita said, this is not going to be the last pandemic. So why are we having an increasing frequency of these epidemics and pandemic threats? And how do pandemics arise, and how can we avoid, preempt, or better prepare for them? And then how can we better respond to pandemics in the future, learning from the lessons, successes and failures of the COVID-19 pandemic? And some of the points I think had been mentioned in terms of investment in public health, One Health, resource allocation, equity, leadership, trust, and some of these other problems that we face in today's world, such as social media. I mean, they can be problems or they can be positives depending on how we look at it. And I just want to end up with emphasizing that things like pandemics are just one part of the bigger challenges that we face on a global scale. So firstly, why are we facing an increase in these epidemic and pandemic threats? Because over in the 1940s, 50s, 60s, we had major achievements in combating infectious diseases. We had vaccines, antibiotics, smallpox was eradicated, polio is almost eradicated. And in fact, in the 1960s, it was believed that infectious diseases were more or less, you could forget about it. But since then, we have had major infectious disease threats, HIV, AIDS, antibiotic resistance, bird flu, SARS in 2003, Ebola, Zika, and it was obvious, these were going to keep on coming. And in fact, in early 2019, I was part of a panel at a Keystone meeting discussing this topic of preparing for the next pandemic. And one of the questions was, what viruses are likely to cause the next pandemic? And my answer there was that it was likely to be either an influenza pandemic or a coronavirus pandemic. And unfortunately, of course, that is what it was. So what are the factors that contribute to this increased frequency of emergence of new epidemics? Of course, we have the microbe itself, and they have their characteristics of mutation, adaptation, but then these characteristics have been essentially the same going back thousands of years. The microbes haven't essentially changed their potential or their properties. What has changed is human activity. So changes in the environment, ecological degradation, deforestation, increasingly climate change will impact the emergence of particularly vector-borne, mosquito-borne diseases. And then we have a whole host of human activities, of course, growth of populations, urbanization, we are more crowded together, which means infections can spread more rapidly. Travel, international travel means that any outbreak that starts anywhere in the world can be a problem everywhere within 24 hours. International trade, intensive livestock industry. At the moment, we have something like 80 billion livestock consumed annually. And these are raised in very large scale, very industrialized type of settings, not the backyard village settings that even 50 or 60 years ago, many of us were used to. And also many of these strain, I mean, even if you look at, for example, chicken that are raised, they are genetically very homogeneous. They are bred for very specific properties. And in most parts of the world, the genetic stock is more or less the same. So it's identical, which means that a virus that emerges, really, if it successfully emerges into that population, it has unlimited potential to spread. Then we have the wild animal trade, and I'll talk more about that. The pet trade, you'll be surprised how extensive that is internationally. Antibiotic abuse, breakdown of public health, lack of political will, human behavior changes. So all of these things are really human activities that are increasing the risk of emergence of epidemics from animals to humans, and a few of them, of course, has potential for pandemic spread. So this is just to show you, for example, this is the human population, and this, for example, is the rate of increase of production of poultry, and here the increase in travel over the last number of years. Now, as was mentioned, I was involved in the 2003 outbreak of SARS, which emerged from southern China and came through Hong Kong. And after identifying the virus and tackling the human outbreak, we were interested to try to understand where this virus came from. Together with one of my colleagues, Yi Guan, who sampled these wild game animal markets in Guangdong, found evidence of a virus that is almost identical to SARS in these game animal markets, in animals like the civet cats, raccoon dogs, and things like that. And when we tested the blood of people working in these game animal markets, many of them had antibody to SARS, although they never had the disease of SARS, meaning the severe acute respiratory disease, but they obviously had been infected with a related virus. So clearly, this was where the jump from animals to humans took place. But then it was later found that these animals in nature do not carry this virus. And it was these small rhinolophus bats that were shown to carry the virus. And these bats also being sold in these massive game animal markets allowed the virus to jump from bats to these animals, persist in these animals, and repeatedly expose humans until such time as the virus adapted to then spread in humans. And that is how that outbreak started. So at that time, convincing the Guangdong authorities to close these animal markets almost certainly prevented the re-emergence of SARS. You remember that the human outbreak, luckily, was contained within 6 months. Essentially, the transmission in humans worldwide was halted. But if these markets had not been closed, following the evidence that was presented to them, the outbreak would have re-emerged from this. I'm almost certainly sure of that. So that intervention prevented the reemergence of that 2003 SARS virus. Now, of course, I think the question was raised, I heard yesterday, as to the emergence of the COVID-19 or the SARS coronavirus 2. And the question was raised yesterday as to whether this was a man-made virus. And I can very clearly and categorically state that no coronavirologist who understands the virology of coronaviruses did believe or does believe that it was a man-made virus. I mean, that is completely impossible. And in fact, even the CIA, which President Biden commissioned to investigate the origins of SARS, because this issue sadly had got so politicized, in their report, they also ruled out man-made origin of the virus, meaning an engineered virus. Now, of course, whether the virus escaped from a lab is a different question, and we can discuss that because it's something that you can never disprove. But anyway, if anyone wants to discuss it, I'm happy to discuss it in the discussion period. But I think it is sad to say that the reason why it got so politicized and distorted was because very powerful politicians in very powerful countries wanted to divert their own local public attention from their failures to try to find some other person to blame. So that is sadly where we are, and sadly also it has led to a major disruption in the relations between two of the most powerful countries in the world today. Now, this wild animal trade is something that is extremely extensive, and I think many of us don't appreciate how extensive it is. This, for example, is an endangered species which gets trafficked all across the world, particularly coming out of Indonesia, this trade is therefore not only causing health risks, but is also driving extinction of species and loss of biodiversity. A study that was done some years ago found that over a 10-year period, 1.5 billion animals were imported into the United States. And some of these are wildlife. So clearly you have a huge potential for transferring infections from one part of the world to another. And very recently, in fact, this month, there was a study done in the wildlife trade in China, where they sampled something like 2,000 animals that were being traded, and they identified 102 different viruses, 65 discovered for the first time. And 21 of these were considered to be potentially high risk to humans or to other domestic animals. Now, the civet cats, if you remember, I told you this was one of the animals that were responsible for the emergence of SARS in 2003, was one of the species that carried the highest number of these risky viruses. And there were evidence of a number of species jumps from bats to civets, from bats to hedgehogs, birds to porcupines, dogs to raccoon dogs, and also, of course, in the reverse direction. Humans are transferring viruses back to wildlife as well. So this is where the One Health approach becomes so important. I mean, we are talking about essentially human problems in terms of human health, but you cannot tackle these problems of human health by just staying in our human health silo, because as I showed you, these involve interactions with animal health, wild animal health, and environmental health as well. Now, I would now try to come back to our global response to these emerging epidemics and pandemics. After SARS in 2003, the world did wake up to the fact that an epidemic anywhere can become a threat everywhere. And in response to that, the WHO came up with the international health regulations, the revised international health regulations. And that was signed up by almost every country in the world in the International Health Assembly. And the commitments as part of that agreement were that countries were expected to develop the capacity to detect, to report unusual and unexplained outbreaks of disease, develop the capacity to respond to these threats, and also the capacity to monitor and surveil these threats. So, just a few years ago, when an estimate was made as to how many countries, even according to themselves, even according to their own confidence, less than half the countries said that they had achieved these competencies. But clearly, as you can imagine, these are absolutely essential if we are going to be able to reduce the risk of future pandemics going forward. And the Johns Hopkins University, they have a thing called the Global Health Security Index. And in fact, they ranked the United States as the most prepared country in the world, according to their Global Health Security Index. But I think if you look at the response of the United States to the pandemic, one can certainly not say that they were, or by any means, are the best prepared country in the world to face the pandemic, or of this pandemic or the future pandemics as well. Then, of course, after the Ebola outbreak, if you remember, which took place in West Africa in 2014, 2015, again, there was a flurry of activity and multiple reports, and in particular, this particular report commissioned by the National Academy of Sciences of the National Academy of Medicine of the United States. And in fact, this commission was headed by a banker, Peter Sands, who was previously the head of Standard Chartered Bank. So, and their report was titled "A Neglected Dimension of Global Security." Again, not global health security, global security, a framework for countering infectious diseases. And they went on to highlight the failure of the current model for developing countermeasures, particularly vaccines and drugs, based on the current pharmaceutical company type of model. Because which pharmaceutical company is going to invest in developing vaccines and drugs for potential pandemic candidates when there is no certainty that that particular pathogen is going to actually cause a pandemic? So they pointed out that there is a need, they costed the impact of a future pandemic, and they said that it would be economically extremely prudent to invest something like $4 billion annually to enhance the development of vaccines and drugs for these potential epidemic and pandemic threats coming out of nature, coming out of wildlife and domestic animals in particular. Now, together with that, and maybe in response to that, there was an initiative called CEPI. This was funded, I think initiated quite a lot by the government of Norway, joined by Japan and to some extent India as well. They contributed the money and they came up with this essentially to try to identify what are the potential viruses that might cause future pandemics and develop vaccines for these preemptively before they become pandemics. So some of the things on their list actually included SARS coronavirus and also MERS coronavirus and a few other. There were 8 pathogens that they were focusing on. And MERS coronavirus, which if you remember is in the same family as COVID, as the virus that causes COVID-19, was at that time causing problems in the Middle East. And one of the groups who were funded to develop vaccines for MERS coronavirus was the University of Oxford group. And indeed, it is that development, trying to develop a vaccine for MERS, that they were able to pivot very quickly to SARS coronavirus, because these are essentially very related viruses. So the investment that CEPI had put in to developing a vaccine for MERS was fundamental in developing what is now called the University of Oxford AstraZeneca vaccine. And this is some of the team members there. And in fact, one of the clinicians who was responsible for a number of those clinical studies of the Oxford vaccine is a Sri Lankan, in fact, Maheshi Ramasamy. And then, of course, in parallel, there was the development of the RNA virus technology. And it is important to note that these RNA virus vaccines, whether they were, what is called the Pfizer vaccine and the Moderna vaccine. Now, the Pfizer did not develop the vaccine. It was actually developed by a company called BioNTech, a very small biotech company. And the brains behind that was this lady, Kathleen Kariko, who is Hungarian-born. She finished her PhD in Hungary, went to the United States to do her postdoc. And in 2005, she made a very important discovery. She was trying to understand how you can inject RNA into cells without triggering an abnormal response in the cells to the RNA. And that was, at that time, she was not thinking of vaccines. She was thinking of very basic fundamental research. But it is that research really that was the foundation for the RNA vaccines that we are using today. But it's interesting also that she never succeeded in becoming a professor in the United States. And ultimately, she had to leave the United States and go to Germany. And that's how she was involved in the BioNTech company, which actually developed the vaccine. Pfizer essentially just scaled up and marketed it. And similarly, the other RNA vaccine, Moderna, also is a very small company. So these were not developed by the large pharma companies that you might think about. But then Dr. Palita Abekun, of course, also mentioned the tragedy of vaccine delivery. I mean, one of the triumphs, of course, of the pandemic was the speed with which these very safe and very effective vaccines were developed. But I don't have to remind you of the statistics. I mean, 9.5 billion doses administered as of the end of January, but 36 states have vaccinated less than 10% of the population. And there is a huge inequity, as you can see here, in vaccine delivery, and how we can do better in the future, I think is going to be a major challenge. Now, this, of course, has been a hot topic of discussion, and there is, there's a lot of discussion about patents and intellectual property issues and things like that. But it's obviously very easy to try to focus on something like that. But I think it is a much bigger issue than just intellectual property. I think we do need to develop regional vaccine manufacturing capacity in different parts of the world. For example, Africa has 17% of the global population, but only 1% of vaccine manufacturing capacity. And yesterday, I think we heard from Professor Mukherjee a very interesting comment about the Indian experience with vaccination. I mean, the State Serum Institute, as he mentioned, is one of the global powerhouses of vaccine production, and they in fact did a great job in linking up with AstraZeneca and also with another company called Novavax very early in 2020, and they were going to, I think, make a huge contribution to the global vaccine supply. But as Professor Mukherjee pointed out, this was, again, one of those examples where bad political judgments, misunderstanding of science led to very bad decisions. And, he went through that story. So I think we really have to enhance global vaccine capacity, even in peacetime. And we also need other things. For example, we need stronger and harmonized regulatory authorities. Again, if you look at the situation across Africa, each country has its own regulator which can permit or accept a vaccine for use in that country, and that makes it very difficult because many of those countries don't have strong regulatory authorities. So right now there is a initiative to try to have a pan-African regulatory authority. And I think we also have to strengthen biomedical research infrastructure. Now, again, one of the triumphs, I think, of the to come out of the pandemic is this COVAX facility. Now, I mean, of course, it has not delivered all the vaccines that we would like to the world, but the fact that it had been thought about and they did all the right things, but unfortunately, they did not have sufficient funding to do the job as effectively as they would have liked to do. So again, it's a great initiative, but it's something that clearly has to be strengthened much further with global international commitment and more funding going into it as well. So last year, there was, in fact, independent panel for pandemic preparedness and response. So this was led by Helen Clark and a panel of other people. And these are some of the recommendations to come out of it. And this last one is what I have been talking about. For example, the issue of pre-negotiated platforms for tools and supplies for immediate health responses, particularly countermeasures such as vaccines and drugs. But then that's not the only one. There are many other important things. Invest in preparedness now to prevent the next crisis. Raise new international funding for pandemic preparedness and response. So you remember, this was also something that was pointed out by the National Academy of Medicine Commission in 2018. Much better surveillance systems for new disease outbreaks. Strengthen the independence, authority, and financing of WHO. Now, again, WHO is also one of those organizations that many people found it very easy to criticize. Again, when they found problems, their own failures, as I told you, you always try to blame somebody else. And WHO was also one of the places that was blamed. But I must say, and since I'm not from WHO, but I certainly have worked with WHO going back to 2003, SARS, etc. I mean, WHO has done quite a good job. I'm not saying anybody has done a perfect job. You know, we all have failings that we have to learn from. But if you compare how well many countries have done, particularly big countries, I think WHO has probably done a better job than most of them. But we have to accept the fact that, from what I heard, and if Palita is on the line, he can correct me, what I understand is that the total budget for WHO for all its global activities, not just the pandemic, I'm talking about everything it does about communicable diseases, vaccination, non-communicable diseases, heart disease, and everything, annually is of the order of what a big hospital in the United States would get for a year. So how can we expect very much more from WHO if it is not properly funded with independence to develop a strong infrastructure? Secondly, we have to, people may not understand, but WHO really has no power to walk into a country and demand information or specimens or anything. It has no international power to demand anything of any country. All it can do is to persuade. So this is exactly what the independent panel is saying. Strengthen the independence, authority, and financing of WHO. And I think that is extremely important. Then elevate pandemic preparedness and response to the highest levels of political leadership. Now, usually health matters are regarded as not so important. I mean, it's believed to be a economically draining activity and left to more junior ministers to do. But I think pandemic COVID-19 has clearly showed that it affects every aspect of economies, society, and our whole lives. And also that national pandemic coordinators have a direct line to heads of state or governments. So these are some of the things that the independent panel itself has recommended that have to be done so that we can respond better to future pandemics. Now, so one of the things that, in fact, that we, some of our own research back before the pandemic, in fact, we were interested in how viruses transmit from people to people. And we were studying influenza and coronaviruses, and we showed that what we had is people with infections breathing into an apparatus where we could measure the virus coming out and the particle sizes that were coming out from their breath. So we could show that the other coronaviruses that have been circulating in humans come out of human breath, both in large particles and small particles. And importantly, we show that if we have the same person wearing a surgical mask, essentially you remove the infectious virus from the air. So that, together with the fact that the understanding that COVID-19 could be transmitted even before people become symptomatic, led to the recommendation to wear a surgical mask, not just to protect yourself from getting infected, but because anybody may be infected without knowing it, and to reduce transmission to others. So that was the basis of that recommendation. And more recently, of course, the US CDC has come out with this guidance with a large ecological study where they were able to show that even a simple cloth mask reduces transmission by about 56%, a surgical mask by 66%, and N95 mask even better. But again, we have powerful global leaders taking completely contrary views to very simple public health measures. And this led to the New England Journal of Medicine, which is probably the most prestigious medical journal in the world, at the end of 2020, to write this editorial, and it's headed "Dying in a Leadership Vacuum." And in fact, it was the most sharp indictment of an international leader, and in this case of President Trump, that I've ever seen any medical journal writing. So it just shows that leadership is important, and science-based decision making is absolutely important. And I think that again is a point that was made by Professor Mukherjee yesterday. In the same vein, we have the issues of clinical trials to recommend drugs for use. I won't go into it in detail, but it is extremely important to have large-scale randomized clinical trials to decide whether a particular drug is effective or not. And that is how, for example, these particularly led from the UK, showing some of these drugs, such as dexamethasone, to be effective, whereas other drugs, such as hydroxychloroquine, to show that there has no effect at all. Then we have the supply chain issues, things like masks and other essential goods. And this, again, was something that was pointed out long before the pandemic, that a pandemic such as this is going to hugely impact supply chains and is going to really disrupt both health needed items as well as the whole economic supply chain system. Then, of course, we have other issues such as contact tracing, and now we have the possibilities of much more intrusive surveillance, such as digital surveillance or mobile surveillance and things like that. And there are, of course, benefits of this, as has been shown in many countries, but there are also risks in terms of personal privacy. So we have to address that. And then we also have to consider this issue of balancing individual rights versus collective benefits. And what I'm showing here is the protests in Canada, where a small group of truckers are protesting the compulsory vaccination of people who travel across international borders. And finally, I think we really have to deal with this whole problem of social media and what is truth. So this whole question of rumors and absolute misinformation, which can be spread extremely rapidly. And unfortunately, many people very susceptible to believing this, means that dealing with pandemics becomes a major problem. But of course, this is not something only for pandemics. It is a problem in many other areas of life, and we really have to work out how to do this better. And in fact, I would strongly recommend, if you haven't seen this movie called Contagion, that you do watch it. It's a movie that was made, I think, 13 or 15 years ago. But all these problems, including the problems of social media and so many of the other problems that we actually faced during COVID-19, was foreseen back at that time and very, very accurately shown in this movie. So I think, unfortunately, we cannot say that we were not warned. All these problems that we were facing in the pandemic have been well predicted way before the event. So the longer term impacts of the pandemic, I don't know how much of time I have, but I'll try to be quick. The social, psychological impacts have been pointed out. So vaccines are good at preventing getting disease, but we really have a need to boost our morale as well. The economic impacts and supply chains I talked about, the increase in inequality has been talked about, and I think will be talked about again, and educational and development impact on children. The longer term effects of COVID-19, what is called long COVID, we still don't fully understand the impact of that. And then, of course, the impact of the pandemic on affecting other routine healthcare, sort of blood pressure, hypertension, diabetes, and all these other routine care delivery has been affected, as well as childhood vaccinations have been affected. The misinformation campaign problems. And of course, there have been positives as well. So for example, the understanding that people can work from home, for example, quite effectively, can be a positive. It means less pollution, less traffic on the road, and maybe things that we can keep even after the pandemic finishes. But then, as I said, I want to end talking about beyond pandemics. Now, as I told you, the emergence of pandemics is because we really are living beyond, I mean, it's all because of things that we humans do that are disrupting the ecosystems and the biodiversity of our planet. And this is not purely pertaining to pandemics, because this also pertains to what we are doing in terms of polluting our environment, in terms of air pollution, in terms of climate change. So we really are living beyond the means of our planet, beyond the sustainable capacity of our planet. And in nature, nothing can grow forever. So I don't, I think, I mean, our obsession with perpetual growth of GDPs is not, I think, something that is sustainable. So I think we risk rupturing the limits of planetary sustainability unless, as a global community, we change our way to development. And so a way forward to a better sustainable future. So this is a very, very good article that is published by Hinchcliffe and others, and I would strongly recommend that you read it. And what they say is that COVID-19 is a symptom and not the cause. It's a symptom of planetary dysbiosis, habitat destruction, illegal wildlife trade, poor practices in livestock production, and non-sustainable lifestyles. And they say we need to recalibrate our values and rewards, a shift away from self-care to systems that help sustain the One Health and planetary health perspectives, to move away from human exceptionalism to be less anthropocentric, meaning that we should not think of planet Earth as just focused on supporting humankind. We really have a whole ecosystem to try to support. The importance of public health, One Health, and planetary health perspectives, balance individual versus the collective, inequalities, and so many other things. But I think I will just quickly go on to finally just to reflect that historically, during the 2003 SARS crisis, during the 2008 financial crisis, or in, for example, eradicating smallpox, even at that time, in spite of Cold War rivalries between the West and the Soviet Union, the world came together to tackle many of these crises at that time. But unfortunately, in COVID-19, that global cooperation failed. Even if you compare it with the global cooperation during the 2008 financial crisis, with COVID-19, we had none of that. And why was that? My own feeling is that it was the leadership in the most important countries in the world that was different. But essentially, the science was exemplary, and personally, I know that scientific collaboration was excellent. But at the political level, it was far from excellent. So I think I'll just end with this. I mean, of course, nobody exactly knew what Mahinda Thera told King Devanampiya Tissa, but I think this is a quote by Anuja Fernando. And it goes, "O great king, the birds of the air and the beasts of the earth have an equal right to live and move about in any part of the land as thou. The land belongs to the people and all living beings. Thou art only the guardian of it." And I think we would all do well to remember that and live by that precept. And thank you very much.
Thank you very much, Professor Perez, for sharing your extensive insights and knowledge with the rest of us. I think we can take only a couple of very quick questions. I think, can we put up the slide very quickly? Yes. So the first question is, and please, a very quick answer if possible. Can we dream that there will be a phasing out of COVID-19 by mid-2022, or is it too early, at least by end of this year?
Yeah, so I think essentially the Omicron variant that is spreading worldwide now, of course, it is causing some major challenges, but it is, as long as it is spreading in a vaccinated population, we have a lot of evidence to suggest that vaccine followed by natural infection, particularly with a mild virus like this, provides a big boost to the immunity and also broadens our immunity beyond just Omicron or beyond the old virus or beyond Delta or whatever. It broadens immunity to cover, hopefully, even future variants. So I think the combination of vaccination and natural infection over time at a population level will bring us, I think, to a much better level of population protection to the future variants that may come. But I don't think that the virus is going to disappear, as I think Palita mentioned. It is going to be with us for forever, essentially. But the human immunity will be much better. So I think we should be able to move out of the acute response phase, as Palita put it, to the more sustained control phase, certainly by the end of the year. Yeah.
Thank you. That was the question by Arya Sumanasinghe. And the next one, very quickly, from Professor Priyan Dias. Do you think it'll be better to promote role of science advisors, or do you think scientists can become politicians and help the situation?
I think scientists definitely have to be able to communicate very effectively to the general public and to politicians. But politicians have their role. And I mean, of course, there's nothing to stop scientists becoming politicians. And indeed, for example, the success of places like Germany is because, people like Angela Merkel came from a scientific background. Sadly, many of the global leaders don't come from a scientific background, and that is a disadvantage. But I think, politicians have a bigger perspective. They have to balance many issues, but they have to be scientifically literate. And that is where I think we really have a challenge. And the challenge is both sides. I mean, I think as scientists, we have to be much better able to communicate in a way that non-scientists understand, but equally, politicians really have to respect the scientific community. But what I really fear is that in many parts of the world, experts, not just scientists, I mean, experts are becoming marginalized. I mean, they're almost being regarded as the enemy. And this is really very concerning, and we really have to deal with that.
Thank you so much, Professor Perez. I think we'll have to let you go because of the time constraints. So I think we can move on to the next keynote address that will be delivered by Professor James and Mills. It is a recorded presentation, but Professor Mills will be with us to answer questions. Professor James and Mills is Deputy Director and Provost of the London School of Hygiene and Tropical Medicine, and Professor of Health Economics and Policy. She studied at St. Hilda's College, Oxford, graduating in History and Economics. She joined the London School of Hygiene and Tropical Medicine and became a professor in 1995 and Deputy Director and Provost in 2012. She's a worldwide authority on health economics with a particular focus on creating efficient and equitable health systems in low and middle income countries. She has held the position of President of the International Health Economics Association. She has researched and published widely in the fields of health economics and health systems in low and middle income countries. She has a CBE for services to medicine and is a fellow of the UK Academy of Medical Sciences. She was elected a fellow of the Royal Society in 2013, and 2 years later, she was made a Dame in the Queen's New Year Honours for services to international health. So I'm truly privileged to ask her to make this presentation, which will be in the form of a recording. And as I mentioned, she will be with us live to answer questions. Over to you, to the technical team.
Many thanks for this opportunity to speak at this webinar. And I'm really honoured to have the opportunity to talk about adaptable, responsive and equitable health systems and the impact of COVID-19. I must apologise for not doing this live. You may have seen that we've had a number of storms in the UK recently, and the power supply to my house has been unreliable, and I didn't want this presentation to crash in the middle. But I do hope to be available to take the Q&A afterwards. So what I want to cover in this talk is the health system and health system goals and variation in health systems across the world, providing a bit of backdrop to health systems in general. And then I'll come on to talk about the health system impact of COVID-19 and speculate on the future shape of a health system. So firstly, what is a health system? People often complain that they're really not sure what a health system is. So I thought I'd start by a brief definition that health system is all organizations, institutions, and resources that produce actions whose primary purpose is to improve health. WHO has defined relevant health systems goals back in 2000, and they're generic, but still relevant today. So 3 goals: good health, both in its absolute level and its distribution across individuals and groups; fairness in financial contributions, in other words, that people should pay according to ability to pay; and responsiveness to people's expectations both in the level of responsiveness and its distribution. More recently, this has been framed within the context of universal health coverage, ensuring that everyone can access good quality care, which is now a target within the Sustainable Development Goals. Also more recently, global health security has become considered as another important health system goals, defined as the activities needed to minimize the risk and impact of acute public health events that endanger health across geographical boundaries. And this focus on health security is, of course, a response to global waves of infectious disease, starting especially with SARS in 2003 and now with COVID. This emphasis on global health security has led to a concern with adaptability and resilience of health systems. Resilience, the capacity of health actors, institutions, and populations to prepare for and effectively respond to crises, maintain core functions when a crisis hits, and informed by lessons learned during the crisis, reorganize if conditions require it. But we need resilience in the face of crises and pandemics, but we also need to recognize that health systems face many challenges, and therefore what might be called everyday resilience is important. Ability to be resilient in the face of routine and multiple challenges. In addressing health systems, I'm going to have in mind its four main functions. Financing, conventionally divided into raising revenue, raising income for health services, pooling it so that it's pooled across population groups and the risk is shared amongst that group, and then purchasing, making sure that health services are purchased or resources are allocated to meet the needs of particular population groups. Second area, service provision. The third, resource generation, making sure the human resources, physical capital, pharmaceuticals, etc. are available. And then the fourth, stewardship, concern for the functioning of the entire system, including within that regulation. So these functions are provided in a system characterized by four main players. In the top left-hand corner, the population and patients who seek care from health providers and may pay them directly. The providers of services who provide those services. And then thirdly, the pooling and purchasing agencies who may receive money from people, give them financial protection, and reimburse providers for services. And then on the right-hand bottom corner, the government and professional bodies who both handle some of the payments and also have the responsibility for regulating the entire system. What I've just talked about has more of an economic lens, looks at the health system as flows of services and patients. But we can also see health systems as social institutions. They're complex social and geopolitical institutions with different sets of relationships, for example, between provider and patient, employer and employee, between different providers. And in this context, I want to particularly emphasize the importance of trust, which has been shown up as a real consideration in the COVID pandemic. The trust of patients or population in professionals, or of people in government, or providers in government. Health systems may also be seen as a demonstration of social solidarity. It's frequently said within Western Europe, for example, that health systems are a manifestation of a society's willingness to invest in solidarity. But health systems can also be seen as a means of embedding human rights, the human right to good health and to access to healthcare. I've introduced health systems very generically, but they are hugely diverse across the world. For example, one can look at differences in spending patterns. In this figure from the WHO, ranging from less than $50 per spending per capita to way over $2,000. It's not just absolute levels of spending that varies, but also how money for health services are raised. So this shows the distribution of health expenditure by sources of finance across different country income groups. In a low-income country, you see a dominance of out-of-pocket payments. That's the red pie in the pie chart, with a smaller proportion covered by national tax and social health insurance, and a significant but still a minority share coming from donors, from external funding. At the other extreme, in high-income countries, you see a great majority of health system funding coming through mandated payments, either through mandatory taxation or through mandatory social health insurance systems, and a much smaller proportion coming from out-of-pocket payments. And then between those two country extremes, you see the lower middle-income countries and upper middle-income countries with a falling share of out-of-pocket payments and a rising share of mandatory payments. So clearly the impact of COVID will vary hugely depending on the extent to which a health system is financed out of pocket or financed by government and mandatory insurance systems. Other dimensions of health systems also vary by country income level. And at the risk of gross generalization, I summarize some typical structures on this slide. So for example, in low-income countries, financing a limited share of government revenue, high share from donors and out-of-pocket payments, as I've just shown. Pooling is mainly for those who can access public services. Services are provided by hierarchical management with very limited formal priority setting, and service delivery tends to be fragmented with a large informal sector and a relatively small formal sector. At the other extreme, in high-income countries, a high share of mandatory funding, low share of out-of-pocket payment, universal coverage almost everywhere, often with a single pool, like that of the National Health Service in the UK that covers the whole population. There's much more formal priority setting processes, decisions on what services should be made available to the population, especially via the means of contracts between purchasers and providers. And service delivery is largely formal and regulated with strong professional control. And then in the middle, with the middle income countries, you have a more diverse pattern, mix of different sources, mix of different pools, often with different healthcare benefits for different pools, different healthcare arrangements for different pools, and a somewhat fragmented pattern of service delivery with various public and private formal sectors, and still quite a significant unregulated sector. So I mention these differences because the impact of COVID will be different across these different country settings, and we need to keep that in mind. So before I get on to talk specifically about COVID, I want to mention and summarize the common health system challenges across the world that pre-existed COVID. Common across all countries is that resources are limited relative to spending opportunities. Obviously, to the extent that's true, will be far more the case for low-income countries than it is for high-income countries. But even in the rich world, we're very conscious of the inability to finance all health services that people would like to have access to. There are inequities in financial protection, in access to services, and in service use. And again, those differences exist in high-income countries as well as in low-income countries, even if the magnitude of the inequalities differ between different high-income countries. There are inefficiencies in the mix of services and in service delivery. So, for example, overprescription of drugs, overuse of antibiotics, even in the poorest countries as well as in the richest countries. There are the challenges of globalization, with health worker migration, challenges in meeting health worker needs, the speed of spread of infectious disease we've seen with SARS and COVID. Publicly managed health systems are often seen as unresponsive and bureaucratic. This has been the case pre-COVID, but a very recent article in The Economist emphasized the challenges and what's been going on. The quote, clunky, costly, highly regulated health systems are being shaken up by firms that target patients directly, meet them where they are, and give them more control on how to access care. And I'm going to come back to that later in the context of COVID. So this provides the backdrop for the impact of COVID on health systems. And I've structured this by the framework I presented earlier, looking at populations and patients, providers, pooling and purchasing agencies, and government and professional bodies. And in the boxes, I summarize the bullet points that I'm now going to cover in the next 4 slides. So firstly, the impact on population and patients. There's been reduced access to care. For example, that may have happened because people have been asked to work from home and services are less accessible to them, or it may be because they've fallen out of employment and their healthcare coverage was associated with their employment. There's been a reluctance to seek care, whether because of fear of infection at health facilities or awareness that health facilities have been overburdened with COVID treatments. There have been worsened health inequalities. We've seen the inequality information about the impact of COVID on different population groups, for example, by ethnicity within the UK, but also worsened health inequalities because as people fall out of employment, as poverty increases, that accentuates health inequalities. And then there have been increased needs because of COVID, because of long COVID, because of the mental health consequences of COVID. There have been the non-COVID unmet needs, and of course, the increased needs as a result of increased poverty. Secondly, the impact on providers of services, most obviously perhaps in the death from COVID of providers, in illness, in burnout related to COVID because of the huge pressures on health providers. We've seen the balance of provision pivoted to COVID and a reduced ability to provide other services. For example, a recent review showed that across 20 countries, healthcare utilization decreased by an overall median of 37%. There's been accelerated online provision of professional services and self-monitoring. In the UK, for example, a lot of GP consultations have moved online, and there's been greater reliance on self-monitoring of chronic conditions and less frequent follow-up at health facility. There's also been accelerated growth of healthcare as a consumer product. We've become used to going to the pharmacy to pick up our tests or to get treatment. That's a pre-existing trend, but one that I think has become much more widely known and accepted. And then increased online training and education, perhaps the silver lining in that training and education has been more accessible by going online. Thirdly, impact on pooling and purchasing agencies. There's been the reduced insurance coverage as people's employment decreases, seen, for example, in the US. Pooling and purchasing agencies have seen an enforced change in priorities, having to devote huge volumes of their resources to deal with COVID, which has led to the backlog of non-COVID treatments. These agencies have had to adapt to a more diverse provider market and new entrants, as a lot more firms have come in offering diagnostic tests or treatments. And also, I think COVID has accentuated the problems of disinformation on healthcare products, particularly with the attention paid to vaccines, to vaccine hesitancy, the anti-vax attitudes, and to information about treatments and what treatments might be used for COVID. And then finally, impact on government and professional bodies. Obviously, first and foremost, the huge cost burden of COVID, especially for governments who have the resources to spend and to divert to COVID. They factor an increased role of government, which has been to a greater or lesser degree a comfortable increase for governments. very visible conflicts and coordination challenges between agencies and levels of government perhaps tested the coordination within the health system as never before. And disagreements, certainly in the UK, between what should be a central role and what might be a local role, with, for example, initial decisions favouring central action rather than use of the British system of local government and primary care. A lack of real-time data for decision-making and rapid development of online systems of collecting case data and of informing individual behaviour. And increased tension between societal and individual needs and preferences in decisions on lockdown, when to relax lockdown, and what approach to take to COVID. Within this context, I want to focus especially on the implications of COVID for the approach to public health. Generic health systems frameworks in theory encompass public health, but it tends to be ignored. And it's very clear that COVID has highlighted the importance of the public health element of the health system. Things like surveillance, case finding, influencing health behaviours, vaccinations, things that a long time ago we paid a lot of attention to, but which has been ignored in recent years. And COVID has also highlighted the critical relationship to the primary care level of the health system, not just the public health system, but also the primary care level and its role in dealing with immediate population needs. If one looks at the health system's literature, there's been limited research and evidence on the public health system. It's clear that it's strongly influenced by constitutional arrangements, particularly the distribution of powers between central government and local levels. Arrangements for healthcare and public health are not necessarily the same. For example, local government has a key role in public health in the UK, but the health services are centrally organised and financed. And there's variation across countries in what functions are considered within government scope. Pre-COVID, this has begun to receive greater attention. And for example, there's been recent exploration comparisons in the EU by the European Observatory. This table sets out the organisation of local public health institutions in 3 European countries. In the UK, for example, in England, there are public health departments in local governments at the local municipal level with a high degree of autonomy, no formal upward reporting, and responsible for the planning, commissioning and delivery of local public health services. In France, in contrast, there's no formal organisation, but rather loose networks of NGOs, local governments and local health insurance offices. In Germany, in contrast, a lot of local public health offices at municipal level, largely autonomous and with a wide range of health protection and public health responsibilities. And it's interesting to note that in the early months of the epidemic, Germany was particularly able to use the resources that it had within its local public health offices, whereas in contrast, the British government chose to act at the national level rather than to make use of the public health departments and the GPs, though that's now changed to some extent. More broadly at local level, there are a huge number of agencies that need coordination. And I've taken this diagram from the US CDC, showing all private, public and voluntary agencies that contribute to the delivery of essential public health services within a jurisdiction. And you can see how many different entities need coordinating, organising. And I think this demonstrates how much more thinking and analysis there needs to be on a local public health system and how it can best respond to an emergency such as COVID. So, to conclude on the long-term impact of COVID, I think it's challenged health system capacity and coordination as never before, but it provides an opportunity to reconceptualize health systems and strengthen research on neglected issues, especially public health functions. And it requires all countries to reflect on how they govern, finance, and provide essential public health functions in order to shape a more adaptable, responsive, and equitable health system. So what might be the future shape of health systems post-COVID? And this obviously is hugely speculative. I think they'll be more decentralized. There'll be more initiative in the hands of patients, households, communities, and local agencies, a trend we've seen coming anyway, but which COVID will accentuate. There'll be a more diverse provider market, greater participation of private sector agencies directly interacting with clients, not via a professional gateway. I think we'll probably see that coming in more rapidly in low and middle income countries, since the ability of professionals to slow down the pace of change is greater in higher income countries. I think there'll be much greater online advice, monitoring, and support to maintain healthy lifestyles, accentuating the pre-COVID trend. I think that governments and professional bodies like medical and nursing associations will struggle to regulate and coordinate, and this will need new approaches fitting the digital age and particularly addressing the challenging issue of data governance. I hope that we'll see stronger national and local public health systems, for example, with effective early warning, surveillance, and management of infectious disease, more coordinated global, national, and local agencies, and standing research capacity that is able to rapidly respond as new pandemics hit us, as they surely will in future. And as I said, this is not going to be purely driven by COVID, but I think COVID has accentuated the speed of change and reinforced what was happening anyway. Thank you.
Thank you very much, Professor. I think we have a few questions on the chat box, which can be projected by Randy. Yes. Professor Madhumanar, would you like to elaborate on this or read it out?
Let me read it out. Yeah. What I said is, in any unforeseen event of the pandemic magnitude, there are winners and losers. We often look at the losers with sympathy. At the other end, there are those who became exceptionally rich and powerful, while the latter is not focused in many inquiries.
Thank you very much. And that's a really interesting question and a really important one. And I think that what has particularly concerned us in the UK is the issue of the award of contracts, the extent to which there are private sector agencies that have benefited hugely, and that the process of awarding very, very valuable tenders at the central level has not followed the due process that we would normally require. I think I would not accept necessarily that this been ignored, but of course, anything that involves money and power can be difficult to challenge and is not always looked into. I agree with that, but I definitely think it should be called out, especially where public procurement procedures or where there are other ways in which the rich and the powerful have benefited and others have lost.
Thank you, dear man.
Thank you for that. If you can, there's another question. It is actually from me. In decision making for future regarding investing in health system strengthening, if we focus on a resource poor settings, since you have done many studies in such areas, what are the factors that should be taken into account to help them, help such a country prioritize the needs?
As an economist by training, I have to say, first and foremost, it's to allocate your resources in a way that will provide greatest return. So criteria like cost effectiveness and so on is a good approach to that. But I'm not that purist in how I approach that, because I think one has to recognize that there are other aspects that we value about healthcare other than just the cost in relation to the effects, and that there are many effects that are less easy to quantify, particularly what one might call the caring function of the health system, that a particular procedure may not have such visible health effects, but the act of caring in itself is a benefit of the health system, and that those are less quantifiable benefits. But nonetheless, allowing for some vagueness around the margins, I would say that cost effectiveness and to choose the interventions and the approaches that give you the greatest improvement in health, given the resources invested, is the best guide to action.
Thank you. Yeah, we do have another question from Professor Preparedness. Would you like to read it out? Or?
Well, it's just this idea of equity. I mean, in this whole reconceptualization, and I think you had a slide about differences in resources across countries, but also perhaps within countries. I mean, yeah.
Yes, and I think the issue of the challenges facing resource poor countries are huge. I mean, if we think even in the rich world that we have to prioritize and ration, then far more that is the case for countries with fewer resources available to them. I think that to the extent that I suggested there is a long-term trend towards decentralization and initiative at the local level, I think to me the main need is to ensure financial protection, because we know that affordability, if with decentralization, the risk is that people who can afford to get services do so, and those who don't have money to pay then cannot access services. I think with the spread of financial protection at local level, I'm then more comfortable about having a decentralized arrangement where people make their own choices on where to get care, whether through a public primary care system or whether by going to the pharmacy with due protection against what they can obtain there. There's obviously the issue that it's not just a concern about equity in terms of access to money to pay for care. It's also a concern about access to education and the information that people have to act with, and that the richer you are, the better educated you tend to be, and the more able you may be to take decisions. So I accept that within a decentralized system where the power of choice is more in people's hands, that there is nonetheless still a significant issue of equity in terms of people's ability to make those choices. But I do think that the key emphasis ought to be on providing financial protection.
Can I ask another question, Nadira?
Please
yes.
do. Yes.
So Anne, the question is about agility also. Maybe your decentralization will improve agility. But, with COVID, I mean, there have been, these sudden rises in cases, and then, the drops. And, sometimes, it looks like health systems have been playing catch up. I mean, any thoughts about how, that kind of thing will improve in the future, or is it just that people have to learn lessons and sort of move on?
So I would hope that where agility is needed, and I fully agree with you that in the case of particularly infectious diseases, you need that. I would hope that the preference should indeed be for decentralizing action, because especially also with an infectious disease where your circumstances are different across a country, and that there are limits on the ability to which central decision making can be as flexible as if you allow local decision making. But I think the key, it really is the local information. Well, it's twofold. It's the local decision makers allocating decision-making authority at the local level, and it's also making sure that you have the information available in order to act on. And I think certainly I think having information available that it should be possible to develop improved local information systems. And certainly some of the actions we've seen in the UK to do with vaccination coverage and so on has been primarily to do with drawing on local resources and local relationships. So, for example, addressing the low vaccination coverage in an Orthodox Jewish community in North London through drawing on their own local organizations that provided ambulance services to interact with them over vaccination. Similar stories in other parts of London to do with accessing ethnic minority groups who weren't being reached by the more formal services. And all of that has to happen locally. So I think I'm more optimistic than you. I think COVID has shown the benefit of that local flexibility and autonomy. And I hope that it isn't suppressed by a national desire to retain control, which is what we actually do see in the UK.
I think we have some time left in the session, don't we, Nadira?
Yes, we do. If
Yeah.
there are any questions, please type in. Anybody, either panelist or
So, and just
Yeah.
to engage you again, I mean, this does not only affect health, but also health guidelines issued, right? So there have been a lot of concerns that the educational system would have fared better if local education authorities were allowed to take decisions about when to open schools and shut them. That discussion has taken place in Sri Lanka, perhaps in other parts of the world also. So that's another example of the benefit of decentralization. Would you think?
Yeah, that's an interesting example, and I didn't know that was true in Sri Lanka. I think in all of these discussions in terms of centralization and decentralization, it's important to think about a country's pre-existing structures, levels of government, which level has the responsibility for what, and then who are the powerful players. So I think in responding to your question, one needs to understand what are the influences on local decision makers on schools and whose needs would they take into account. I mean, we know in some countries, for example, where the teachers' unions are extremely powerful, they've actually preferred to prioritize safety and have kept schools closed for a very long time. In other settings, maybe parents may be more powerful and maybe ensure that schools are kept open. So I think you need to think about the balance of power and who has what responsibility, and then what sorts of decisions will that come to at the local level. But also, I think in the area of education, there's this huge challenge with COVID in terms of how do you weight the benefits of education to children versus the risk of infection, and then also what role do children play in the continuation of, in the transmission of COVID. And I think certainly in the UK, that's been a real dilemma, balancing the sort of value of vaccination against the low risk that COVID presents to children versus the ability of school children to provide a reservoir of infection that then infects others. And I don't think we have any easy answers to how to manage that dilemma. And certainly it's one that involves both a whole host of practical, moral, ethical, and other issues. A very interesting area.
Yes,
Nandi,
you have a question?
I have put down a question for the last speaker. I think it is applicable to Dame Mills also.
Please go ahead. Yeah.
The question is, why a global commission has not been appointed so far, despite the the magnitude of misinformation and divisions of opinion regarding the origins of the COVID and questions about its recurrence in the future. It's a kind of a general question, but why it has been delayed so far? Otherwise, a lot of things should have been clarified through it.
Yes, and that's not a question that I feel myself particularly
proposal
well positioned to answer, except that I think that these issues of the origin of infections get bound up with both national and global politics. And whatever one may think about the sort of technical merit of a global commission, in the end, whether it happens or not, will be strongly influenced by global politics and the particular needs of particular governments to point the finger at particular times. So I suppose I simply accept in terms of the relationship between politics and science that it's an always fascinating interchange, and that one always has to allow for the influence of politics, whether that's at global or national level, the influence of politics on decision making in the area of health and indeed other areas.
Thank you.
Thank you, Professor Mills.
Nadira,
Yes.
Nadira, Professor Perez has his hand up. Yeah.
Oh, sorry, I didn't see. Yes, Professor Perez.
No, I just wanted to address that point about the Global Commission and the origins. I mean, the WHO had a group that went, investigated that, and they came out with a report, which was extremely detailed, extremely useful. Now, of course, it didn't achieve everything, right? As I told you in my talk, WHO doesn't have power to go and demand things of countries, but within those constraints, they did a great job. And if they had been allowed to continue, because that was meant to be the first part of the investigation, and they were going to have follow-up. Now, unfortunately, global politics just blew that apart. And I'm afraid, I'm sad to say, the WHO Director General also, I think because he's looking to be re-elected, also bowed to that international pressure. I'm being very frank here. So that was the problem. It was really global politics. I'm not saying that, China is totally transparent. I mean, they could have been much more transparent, but there's a lot of blame to go around. Thank you.
Sorry, Professor Perez. Can I ask Professor Perez a question now that he is here? Actually, this is something that came out in the early days of the pandemic, and you can answer as well. There were a whole list of things with relative merits for combating the pandemic, like sort of close schools, close restaurants, wear masks, and various things like that. I mean, how scientific is that? I mean, has there been any work done on it so that, the next time there is some infectious disease sort of spread like this, governments and policymakers are a bit more savvy about sort of what needs to be done and, what are the greatest risks? I mean, Professor Perez did mention about masks, but there are a whole other range of things like when should you close schools, when should you close businesses, when should you close pubs and things like that, right?
Shall I have go first, and then I'll hand over. I'll have Dr. Perez. I think it's been one of the really positive things about the pandemic has been the response of the scientific community and how rapidly knowledge has been developed. And admittedly, there's always going to be, it's never going to be as fast as one would like, because it just takes time to collect the evidence. But I think that the body of knowledge on those sorts of things you list, things like masks and so on, has improved enormously over the course of the epidemic and will be of great value in the future. And I think a number of misconceptions have been corrected. what I think is, to me, is one of the most fascinating issues is not the intervention by intervention evidence base, but more the combination of interventions. Because I suppose as a health systems person by background, I'm always aware that no intervention is delivered in isolation. It's always a mix of different things. So the question is, how do they interact, and what is the relative value of one mix of things versus another mix of things? And that's where I think there's been a huge development in modeling skills. And whatever one may think about modeling, it certainly provides a very valuable way of understanding the implications and understanding where we need better information, or where better information actually wouldn't make a difference, that the course of action is clear. So I think that's been, in a sense, one of the positive things about the pandemic, the fact that scientific knowledge has developed so fast, and also in a way that is accessible. I mean, the huge development of open science, open data, the preprints published quickly. I mean, all of that, I think, has been great progress and puts us in a good position for future occurrences of something like COVID.
Thank you so much to Professor Mills for sharing your knowledge and thoughts, and also spending time with us during the webinar. Thank you to both the speakers, Professor Perez as well as Professor Mills, for a very successful session. I think we'll take a short break, although we are a few minutes over time. We'll take a 5-minute break and we'll be back with the leading talks, which I hope you will join. Thank you.
Thank you. Thank you. Thank you.
Hello, everyone. Let's get started with the next session. The next talk is by Professor Emma Tourmaline. Professor Emma Tourmaline, let me introduce her. She is a sociologist of religion and religious studies, whose work is focused on the broad area of religion and public life. She has a long-standing interest in religions and global development, including the gender dimension of this relationship. More recently, she has been involved in projects that also engage with the role of faith actors in humanitarian action, peace building, and health. She has mainly worked in South and Southeast Asia, and more recently in East Africa. She has also carried out research on the role of faith actors in public life in the UK. Her latest book has just been published and is titled Handbook on Religion, Gender and Society, which has just come out. Congratulations, Dr. Tourmaline. Let me take this opportunity to congratulate you on that, and over to you.
Thank you very, very much. And hello to everyone. I think I'm sharing my own screen here, so I will go ahead and do that to get my PowerPoint ready. Is that okay? Can everyone see that?
Yes, perfect.
Okay, wonderful. So the title of my presentation is Religions and the COVID Pandemic, Exploring the Long-Term Impacts. So global health policy and humanitarian response have tended to not seriously consider the role that religions play in health and well-being for the majority of the poor in the global south. International organizations such as the World Health Organization base their approach to health upon modern scientific and secular principles. By contrast, religion is seen as the antithesis of these and not something that necessarily needs to be taken seriously alongside evidence-based and research-led efforts to address health emergencies caused by pandemics or other humanitarian crises, except perhaps when they can be used as a resource to meet global health goals. There is, however, a mismatch between this view of religion at the global level of health and humanitarian systems and how religion operates within the daily lives of those experiencing the highest levels of poverty and inequality, and who are most affected by health and humanitarian crises, such as the COVID-19 pandemic. Within these communities, people are often highly religious, and their religious worldviews play a role in shaping understandings of such crises, including helping to provide a rationale and coping strategies, as well as shaping the decisions that people make about their health. Over the past couple of decades, global health and humanitarian actors have begun to take religion more seriously as a resource to deliver health outcomes, and are much more likely to seek to form partnerships with faith actors. However, such engagement is very much on the terms of the global actors. It is not a consistent feature across all activities, and many still see a bias that views religion as an outdated inconvenience rather than a vital, enduring, and meaningful aspect of social, economic, cultural, and political life. Now, during the COVID-19 pandemic, religion has been seen to contribute towards attitudes that lead to poor vaccine uptake, as well as to situations where religious minorities have been attributed with spreading the virus. Here, the intersection between existing religious tensions and the global pandemic further entrench religious inequality and marginalization. Now, this underscores the apparently negative ways that religion can influence health and well-being, but suggests that instead, religion needs to be at front and center in global efforts to secure better health. This includes facilitating research to better understand these dynamics, as well as seeking to form partnerships with faith actors who know their communities best, many of whom are keen to engage with global health and humanitarian actors to promote better health practices, including vaccine uptake. And just quickly on this slide here, I have some images sort of demonstrating the impact of COVID on religion. And at the center here, many of you will recognize this goddess. This is the Hindu goddess who traditionally was a goddess who was worshipped to cure smallpox, but has also been worshipped during COVID as a way of dealing with the COVID virus. So in this presentation, I will focus on the religion COVID-19 intersection from 3 different perspectives or levels. So I'm going to look at global institutions such as the World Health Organization. Then I want to look at local faith actors such as places of worship and faith-based NGOs. And then finally, I want to look at local communities themselves. In thinking about the long-term impacts, I will also address the following questions. So in what way has COVID-19 impacted on how global institutions engage with religion and faith actors? And then the next level, what is likely to be the lasting impact of COVID-19 on the activities of places of worship and faith-based NGOs? And finally, coming down to the local or community level, what are the long-term implications of the religion COVID-19 intersection at the community level for how people view their health and the decisions that they make about it, as well as for social and economic inequalities? So first of all, in what ways has COVID-19 impacted on how global institutions engage with religion and faith actors? So there's a lot that I could say here, a lot of different organisations that I could speak about, but I'm going to focus on the World Health Organization as a case study. So the history of the World Health Organization's relationship to religion has been captured in an excellent recent article, the details of which are on the slide, which charts the shift from its formation in 1948 to the current COVID crisis. Now, in the early history of WHO, which was founded in 1948, religion was absent as it pursued a top-down biomedical approach to healthcare that focused on individual diseases such as malaria. But by the 1970s, engagement with the Christian Medical Council introduced a community-based and holistic approach to the World Health Organization's work. The Christian Medical Council had already become experts in this, and their move away from an earlier top-down proselytizing missionary-based model of healthcare to one which much more reflected the needs, interests, and skills within affected communities. And this collaboration is widely recognized as having influenced the drafting of the 1978 Alma Ata Declaration, which committed the United Nations and world governments to a focus on achieving health for all through primary healthcare. By the 1980s, the relationship between the Christian Medical Council and WHO had cooled off, but a new phase of engagement came about with a major study that was commissioned by the World Health Organization from the African Religion Health Assets Program, which was called Appreciating Assets, the Contribution of Religion to Universal Health Access in Africa. And that was published in 2006. So against the backdrop of the HIV/AIDS crisis, WHO wanted to understand the role of religion, which the study found to be significant, with over 40% of healthcare services provided by religious institutions. And this approach of engaging with religious institutions and actors to achieve health goals was also seen in polio eradication campaigns and responses to the Ebola crisis in West Africa. And during the Ebola crisis, however, engagement with faith actors particularly found that burial practices, which were spreading the disease, were a problem, but the engagement with faith actors came about rather late in the day, so after the problem had already been identified, but ultimately proved to be successful alongside other kinds of interventions. So what about COVID-19? In what ways has COVID-19 impacted on how the World Health Organization has engaged with religion and faith actors? There's rather a lot on this slide, and I'll talk through it. So the lessons learned from how the World Health Organization responded to Ebola in particular led to faith leaders being consulted much earlier on once COVID-19 hit. Religious leaders were consulted at the start of the crisis, and guidance was produced with practical recommendations for safe religious practice during COVID-19, as well as engagement with religious texts to promote COVID-19 prevention measures. And I've included the front pages of two of the publications that WHO was involved in terms of providing guidance and reinterpretation of religious texts around COVID prevention measures. In addition to this, other measures were taken to embed engagement with religion and faith actors across WHO activities. And we can see this, for instance, in WHO's new information network for epidemics, EpiWin, which has religion as one of the key areas. And you can see this again on the slide here. We're talking about the kind of information that's necessary in order to educate people about how they can protect themselves during COVID, and the various amplifiers or messengers that can get those messages across. And faith-based organizations are very clearly indicated in this model as one of the key actors. So in addition to EpiWin and the role of religion, in 2020, WHO employed a former faith advisor who'd worked for UNAIDS before to guide their work in this area. They've established communities of practice involving World Health Organization staff, researchers, and religious leaders to consult in different areas of interest around the engagement between faith and global health. And more recently, in 2021, they were part of a collaboration that organised, I think was the first major conference that the World Health Organization had organised on religion, called Strengthening National Responses to Health Emergencies, WHO, religious leaders, faith-based organisations, faith communities, and national governments. So quite a lot's going on. So summing up on long-term impact at this level of global institutions. So COVID was not the beginning of the World Health Organization taking religion more seriously. And the response during COVID built on lessons learned from the HIV/AIDS and Ebola crises in particular. However, the scale of the COVID crisis provided the impetus and opportunity to take this learning and scale it up, embedding it in a much more conscious way into WHO activities and increasing the level of consultation with faith actors and at an earlier stage. Now, while in the UK, for instance, our government seems to be treating the pandemic as over and done with, this is not the case in many communities, particularly in the global south, where vaccine uptake is slow. And the strengthening, I think, of relationships between WHO and faith actors in the early phases of the pandemic is going to facilitate a much stronger role for faith actors in coordination with WHO to tackle vaccine hesitancy and to promote uptake. And it's going to be interesting to see the extent to which this will also facilitate a more visible and integrated role for faith actors in future health crises, and possibly across other WHO activities. So, for instance, in forward planning and prevention work. So, having looked at the impact of COVID on how global institutions such as the World Health Organization engage with religion and faith actors, I now want to move to a different level and to examine this with respect to its impact on the activities of places of worship and faith-based NGOs. For long periods during the COVID pandemic, places of worship could not open normally to their communities, and we can see some examples of this on the slide here. I think this one's particularly lovely, where the members of the congregation have sent selfies of themselves for the priest to pin up on the church pews. So some places of worship closed altogether, and others took their activity outside if social distancing rules allowed. And this disruption not only had an impact on the worship and spiritual activities of places of worship, but also meant that their important community outreach work was compromised. The impact of this is not to be underestimated, where for many communities, places of worship are a lifeline, providing food, shelter, and other practical resources, including healthcare and education, as well as refuge and advice for women and girls experiencing sexual and gender-based violence. Just at a time when places of worship were needed more than ever as sources of spiritual resilience and social service, were less able to support their communities. Moreover, when places of worship had been offering support around issues such as sexual and gender-based violence and human trafficking in the past, during COVID, their attention became diverted towards issues arising from COVID, and other services and support systems took a back seat. So to illustrate some of the ways in which faith actors responded to COVID in terms of their outreach work, and played a key role alongside responses of the state, I want to briefly explore a couple of examples. So the first one here is from the Swaminarayan Temple in Neasden, London. This is the largest Hindu temple in the United Kingdom. And through its parent organisation, which is called BAPS, it launched a national community care programme to support individuals and communities in response to the pandemic, calling for volunteers to act upon their religious dharma or duty in this time of need. And this initiative included public announcements and publications, including summaries of government guidance, a series of health awareness to educate the public on its responsibility to help stem the spread of the virus. They carried out thousands of phone calls, visits, and hand-delivered letters to check if local communities needed support. And this extended beyond the immediate perhaps Swaminarayan Temple communities. They delivered meals to vulnerable households. And this example here on the slide, they raised money to donate oxygen concentrators to Nepal for life-saving COVID relief work. And in addition to this, an example which I think is very distinctive of faith-based organisations or places of worship is that on a national day of prayer in England, as a response to COVID, the Swamis in the temple carried out a special ritual or abhishek to Swaminarayan at the temple, but this was also performed simultaneously by devotees in their homes. And this quotation is rather nice here from the website, a woman talking about what this meant for her. A mother from Watford, this is in North London, who performed the ceremony at home with her family, shared, "Thank you for organising the wonderful and divine abhishek. My husband and I are on the front line serving patients and risking our health daily. These prayers give me strength to confront this challenge. I have prayed to Maharaj and Guru Hari Mahant Swami Maharaj to protect me, my family and my colleagues, and for all those who have suffered through this terrible tragedy." So the second example here will be very familiar to many of you, the Savadaya Movement, a Buddhist NGO in Sri Lanka. And similar to many other faith-based organisations, and similar to the work of the Neasden Temple in London, despite being many, many thousands of miles apart, very similar types of activities were initiated during COVID. So this included an awareness campaign, translating official information from the government of the World Health Organization and translating this into different languages and widely distributing it. Then also collecting information from local areas and making sure that the government had access to this so they could better understand the needs and circumstances of local communities. And as with many other religious organisations, opening their training centres, their centres as quarantine locations, and being active in supplying food, health and social welfare services. And there's some examples on here. Some food relief, I think, for children was being carried out here. So just to sum up then and look a little bit at the long-term impact. So for local faith actors, for places of worship and faith-based organisations, COVID presented challenges but also opportunities. The social capital built during COVID is likely to have an ongoing impact on future work, including the strengthening of skills in innovation and flexibility due to having to respond so quickly and in very difficult circumstances, and also the formation of new partnerships to support their work and increase its visibility. And I think it's also very likely that the significant contribution made by faith actors during COVID, which has been widely recognised, will raise their visibility with the state as legitimate partners for future work. And this is important, I think, in settings where relationships between faith actors and the states may have been very difficult or uneven in terms of power relations in the past. So now to the final level, last but not least. So what are the long-term implications of the religion COVID-19 intersection at the community level for how people view their health and the decisions they make about it, as well as for social and economic inequalities? So I now want to have a look at the level of the individual and the community. And first of all, of course, as we've already saw in the example of the Swaminarayan Temple's Abhishek, or special prayer on the National Prayer Day, for individuals, in their homes and in their communities, this helps them develop resilience to handle the pandemic. And this very much points to a distinctive quality of faith approaches that combine tangible, practical initiatives with those that focus on much more intangible aspects of faith identity, such as the power of prayer. And a second area that I've already hinted at, where the relationship between religion and COVID also has an impact on individuals and communities, is with respect to conspiracy theories and misinformation, where trusted religious leaders can play a role in spreading ideas about there being no need for vaccines as God will protect people, or that the pandemic is a punishment from God. And this then impacts upon the decisions that people make about their health. And then the third area, and much more controversially, is the way in which existing religious tensions and inequalities in some locations have been exacerbated by COVID. And I've put a couple of headlines here from newspapers where this was reported, and there's many, many more from all over the world. So in India, for instance, members of the Muslim community were blamed for spreading the virus, building on and exacerbating existing inequalities, where COVID has been depicted, for instance, as a Muslim plot to wipe out Hindus. The result of this has been violent acts committed against Muslims, as well as curtailment of their economic activities, as they've been banned from certain areas and forced to remain at home. And similarly, in Sri Lanka, in both mainstream media and social media, have played an important role in disseminating hate speech, targeting minority communities, Muslims in particular. In a research report based on a project led by Professor Chida De Silva, which was called The Impact of COVID-19 on Faith-Based Peace Building in Sri Lanka, the controversial picture on the slide here, which is taken from Facebook, is discussed as an example of the Muslim community being blamed for the Easter bombings, as well as for COVID. However, Chida De Silva and his colleagues also demonstrate that while this deployment of religious hatred in relation to COVID was a prominent discourse in the first phase of the pandemic, that later on it receded as the pandemic became much more widespread. So we begin to see this discourse less often in the later phases of the pandemic. So again, then, to sum up and look a little bit at the long-term impacts, I actually found it much more difficult to draw some general conclusions about the long-term impact of the religion-COVID relationship at the local level than at the other levels. And I think this probably is because of the diversity of contexts that need to be taken into account. So it's very difficult to predict. And I think that suggests the need for very focused local level research in order to understand these dynamics better. But a few points did stand out to me. So first of all, at the level of the individual and the community, the significance of the intangible dimensions of faith identity alongside the practical support of faith engagement is really clear, that these things go together, they can't be separated. And second, the culture wars that are at play in the COVID domain have been really extreme and widely known about due to social media in particular. So on the one hand, this has meant that misinformation has spread like wildfire, but on the other hand, it has likely brought greater attention to the role that faith leaders played in this, and that this can be damaging when their views are at odds with the scientific evidence. So to what extent will this make people less likely to not trust their faith leaders in the future when their messages conflict with scientific evidence? And finally, COVID has clearly exacerbated existing religious inequalities in some settings, which will have ongoing impacts in the recovery period. However, the Sri Lanka example that I gave would be really interesting to follow up. So what are the underlying reasons for the weakening of discourses that draw on religious bigotry? And has COVID somehow played a role in strengthening interfaith relations, or are other factors at play? I hope I'm still within time. I tried to cram a lot into my 20 minutes, and probably some of the nuances and contrasts that I would have pulled out if I'd have had longer. I've not been able to, but I'm sure that these will come up in the questions and the discussion. So thank you very much for your time and for listening, and I look forward to the discussion.
Thank you, Professor Tomalin. That was very interesting. Professor Tudor Silva that you referred to is also in the audience. I'm sure he'll have some comments.
I hope he joins in the discussion. Yes.
There are a few questions in the chat box. If we can have a look. Is there, yeah, till it is put. Oh,
I'm not sure that one's for me.
No. It was an earlier question. Can we move on to the chat box, please?
Nadira, I had a question. Can I ask it?
Yes, please. Go ahead.
Yeah. So Emma, thank you for that talk. Yes. Now I know, that, from time to time, I have heard of these dialogues between faith and science, right? And I think it is the robustness of such dialogues that take place, prior to or, independent of these sort of crisis situations that sometimes help people to navigate these tensions during these crises. I mean, I'm referring to what you said, that some of these sort of faith communities, ask adherents not to believe in the science, but rather just to believe in some transcendental sort of assistance and things like that. But in order for people to form an opinion on that, I think there needs to be sort of continuing dialogue between, the role of science and faith. I mean, I know in Europe, there were big sort of tensions between science and faith at a certain point in European history. But I think now there seems to be greater sort of rapprochement, I think. I'm not sure that's true of, other sort of religions across the world. Do you have any views on that? Yeah.
Yeah, I think that's a really good point to raise. And actually, I think you're right. Within all religious traditions across the globe, regardless of what country you're in, you get views that both go against the scientific evidence that can be supported by faith positions, and also those that correspond to the scientific evidence. So for me, if it's the scientific evidence that we want to be following and listening to, then forming partnerships and engaging with those faith actors and those segments of the religious traditions that, also share those positions, supporting and facilitating their work is a really effective means of countering those who speak out against the scientific evidence and spread misinformation and help generate these conspiracy theories. So I think, everywhere you get both, even in Europe still, we have both sides, both faith actors who support the evidence and those who don't. But I think, the key is working with those religious actors who support the evidence and want to spread the positive messages, because there are many there, as a way of countering those who dispel the scientific evidence and want to go against it.
Thank you.
Really good point.
Yeah, that's an important point. We have Professor Tudor Silva who has come out with a question. Professor Silva, would you like to ask?
Thank you, Nadira, and thank you, Emma, for that very solid presentation. And I think what you presented is that there is a kind of paradoxical scenario with regard to the role of religion. In some instances, religion or religious groups have triggered hate speech and tension. But in lots of other instances, religious groups have come forward to provide relief, even, like work against misinformation. So both these aspects are there, and I think you brought it out very nicely. What I want to know from you is, what is the overall global trend, both maybe in West and non-Western countries with regard to the role of religion? Particularly, I think you mentioned about peace peace building and their specific role in creating bridges among polarized communities. So I would like to know from you whether you can share any information on the count.
So you're asking about the trend at the sort of global level of engaging with religion, you know, in pursuit of health goals and humanitarian peace building goals and so on. Yeah, I mean, something I didn't really get to unpack, and you know, I'd be interested in the experiences of other people in the audience, is probably over the last 20 years, there's been a much stronger turn to religion within these different domains of global health, humanitarianism, development, and peace building, of wanting to engage with faith actors. And I mean, that's partly a response to the awareness that, you know, religion hasn't disappeared, you know, not only the recognition that it's still a very powerful force in the South, but also in many contexts in the global North as well. And also to do with the security agendas as well, around fears about terrorism and so on. I think there's been much more of an emphasis in wanting to sort of try and understand or engage with particular types of religious actors. But one thing that I see is that, and I mentioned at the beginning of my talk, but didn't really unpack it, is that the engagement with faith actors in these different domains has been very much in an instrumental sense. So very much in the sense that what can faith actors and faith traditions do in order to act as resources to serve predefined health goals, predefined development goals, and so on. I think much more at the peace building level, actually, there's been much more sort of dialogue and cooperation, because you really do need to understand what's happening at the local level. But particularly in the field that I work in international development and religion, that engagement has tended to be much more instrumentalized, and also engaging with a particular type of faith actor. So the very formal faith actors who look like NGOs and can speak that kind of development and global health language. The actors at the local level, so, you know, the people that work in places of worship or perhaps work with very local faith-based organizations, have been not so strongly brought into those debates and discussions. And that, to me, seems something that really has to change, in order that these systems can be much more reflective of local needs on the ground, rather than just engaging with the same actors that look like the secular development actors in order to keep on replicating the same global North-led models. So I think a lot could be done to move much more to the local level, and to hear much more from very local faith actors and local faith communities about how their understandings of health, their understandings of development and so on can influence the global agendas around these topics.
Thank you. Thank you, Professor Tourmaline. Thanks so much for sharing your studies and knowledge with us in that area, which was very interesting. I think we should move on to the next talk, which is by Dr. Melvin A. Jabba. Dr. Jabba is a director of the Social Development Research Center, and he's a full professor of the Department of Sociology and Behavioral Sciences. He obtained his PhD in Asia Pacific Studies at the Ritsumeikan University, Asia Pacific University, and his Master's of Health and Social Sciences. He's currently a co-investigator in this in a study which is titled Ethical Technology Assessment of Artificial Intelligence and the Internet of Things among Gen Z population in the Pacific region, the case of Philippines, Thailand, and Japan. And he was also co-investigating the recently completed project Digitization and Digital Asset Management of Archival Materials in History of Leprosy in the Philippines. So he has done many interesting studies, and he's going to share his experience through a very interesting study that has a very interesting title as well. Go ahead, Professor Jabba.
Thank you very much for the wonderful kind introduction of yours, ma'am. But let me confirm if you can see my slide.
Yes, you can. Yes, we can. Yeah, okay. Now it's
Okay, thank you very much. It was indeed a very nice discussion we have with Emma. It was an interesting topic, but I'm not quite sure if my topic is going to be related to hers, because mine is about symbolic interactionism, which means that it's going to be micro rather than macro, because she was talking about religion, so I'll be talking about how people think about their experiences during the COVID-19 pandemic. So are we good? Just to make sure if I'm okay.
Yes, yes, you're fine. We can hear
Okay.
you. We can see the slides. Yes.
Okay. So the central theme of this presentation involves an example of how a physical object, in this case, a chair. I'm going to talk about a physical object, which is a chair, and in our language, you call it a silya or upuan, which can have different functions and meanings as a result of changing social and environmental conditions, not only as an adaptive response, but as a reification of prevailing social realities. Such realities can either be reinforced or suppressed by these very specific social and environmental conditions. So the paper, which this presentation is based on, is inspired by my personal and hopefully astute observation of how the chair, the physical chair, the thing that we sit on, of how this kind of object has transformed during the COVID-19 pandemic. It's a context that we have in the Philippines. So during the distribution of the relief goods,
Are you moving the slides, Professor Chaba?
sorry, can you hear me? Can you hear me? Sorry, can you hear me?
Yeah, now we can.
Yeah, now we can. There was a disruption. Yeah.
Okay.
I think I'm having a connection problem, but can you already hear me?
Maybe you can turn off your video. Turn off your video and speak.
We can see the slide, but we can't hear you.
Connected? Can you hear me?
Yes, yes, we can see you now, but the slides are not there.
Okay, it's okay. My apologies. I'm having interconnection problem. But can you already see my slide?
Yes.
Okay. So during the distribution of relief goods, or in the local language, we call this as ayuda, which means basically relief goods. In many provinces of the Philippines, families were asked to place a chair outside their home to avoid human contact during delivery, and hence less transmission of the virus. So as you can see in the slides, hopefully you can see there's a picture there of chairs, because again, the families are directed that they have to bring out the chairs outside of their home so that there's going to be no face-to-face contact with the persons providing or giving the relief goods, and then of course the recipients. So unlike in other countries, distribution of relief assistance in the Philippines in the form of both cash and goods was done manually through house-to-house visits and face-to-face cash distribution. Although what is unique in the Philippines, however, is the provision of repacked relief goods which were distributed in local communities. So in this presentation, I discuss how the chair as a physical object represents social realities in the Philippines, even in a situation like viral pandemic. A chair in this regard is taken as a cultural material, and it functions and its function develops through time. This paper is anchored on symbolic interactionism and uses it as a lens in making sense of how objects are given life by humans. Meaning at a specific point in time or in a particular social and spatial context. You see the chair as an object in relation to relief operations during the COVID-19 pandemic. This is Facebook post relating to the chair and to its role in relief goods regarding the can let me confirm if you can still hear me?
We can, yes. Please don't switch on the video. Maybe the connection gets disrupted. We can hear you now, but there was a disruption.
My apologies, I was disconnected, so I don't know where I stopped.
We can't see the slides now.
Shall we try to share?
Hello.
Yes, I think it might be better.
Right. I think we will try to share the slides from here.
Better, yeah.
And Melvin, you can say next slide and so on. And we can go on. Shall we try to do that? Are you on the call? Melvin? Hello, Melvin. Can you hear us?
I think he got disconnected. Do we have his recording?
We don't have a recording. But we are going to share the slides, and if he just uses audio.
Yes.
When he connects, it might work. Right.
Sorry, can you already hear me?
Yes, we can. Melvin, we will share the slides.
Hello.
Yes, the slides are on from this end. Can you please continue just the audio?
Okay.
Go to the next slide.
Can you already hear me?
Yes.
Yeah.
We can hear you now.
Hello.
Can you see the screen?
Yeah.
You're
Sorry,
breaking
can you
up.
already hear me?
Yes, but you're breaking up. Now the slides are on. Can you see the screen?
Unfortunately, I cannot see the screen. But you already.
We have put your slides on from this end. It's on screen. Can you see?
Sorry. Apologies. I'm having a internet connection problem, but can you already hear me? Hello?
Yes, yes, we can hear you now.
Go ahead without the slides.
Hello.
Yes,
Yeah.
if you can just
go ahead without the slides.
Yeah, you can give the talk and we can operate the slides.
Excuse me, can you already hear me?
Yes, we can.
Okay, okay.
Can you see the screen now?
Yes, my apologies. I have having a hard time with my connection, but nonetheless, let me proceed if I'm already clear on your part.
Operate the slides, you can say next slide.
Okay, okay, thank you. So I was saying earlier in my presentation, I'm going to discuss how the chair as a physical object represents social realities in the Philippines, even in a situation like a viral pandemic. A chair in this regard is taken as a cultural material and its function develops through time. This paper is anchored on symbolic interactionism and uses it as a Sorry, I was disconnected again. Can you hear me?
Yes. Shall we request you to record your presentation and send it to us so that maybe we can play
So in this
it
presentation, I will discuss how the chair. Sorry.
we cannot hear you, Melvin. So what you can do.
Yeah, it gets interrupted. If you can send the recording,
we will play it tomorrow.
Yeah.
We will play it tomorrow at an appropriate time.
Is that okay?
Can you call him?
Yes, I think we should move on.
Yeah. Okay.
We have moved on
Can you hear
to
me
the.
already?
Yes, Melvin, what we thought we could do is, if you can send us the recording, we can find time tomorrow. We can allocate a slot and play it tomorrow. Is that okay?
Can we just try at this point? Maybe it's going to work.
Yes, we can try just one last time. We can put the slides and you can talk.
Sure.
Yes.
Yes.
Okay, maybe he has a better connection.
Can you see my slides?
Yes.
Yes,
Yes. You can start from slide 3. We can start from slide 3.
Okay.
You can see the screen.
Let me just. Yes, maybe I can already share my video if you.
No.
It's okay.
Can you see the screen?
Yes. Yes.
Right. So if you can talk with the slides on the screen, we can move.
Yes.
Thank you.
So basically, okay, thank you. So basically, what I'm going to talk about is the experience of the Philippines during the pandemic and during the distribution of relief goods, or ayuda as we call it in the local language. Many provinces of the country were asked to place a chair outside their homes to avoid human contacts during delivery of the relief goods and hence lessen the transmission of the virus. So there's a news report in the Philippines which would describe that relief goods were placed on chairs lined up outside the houses of a village in a local government unit in order to rigorously implement the physical distancing. So as you can see in the picture here, so people were asked to bring out their chairs so that they will be able to get relief goods. And the reason being, again, as I mentioned earlier, is that there should be physical distancing between the ones who are distributing the resources or the relief goods and then the recipients. So unlike in other countries, distribution of relief assistance in the Philippines in the form of both cash and goods was done manually through house-to-house visits and face-to-face cash distribution. But what is unique in the Philippines case, however, is the provision of repacked relief goods which were distributed in local communities. During the said distribution, the chair was used as a conduit object. Given this scenario, I began to realize that in the COVID-19 experience, the chair as an object has been assigned another physical function and has been given another life. Perez in 2003, based on the screwdriver philosophy, argues that it is humans that assign functions to objects. In other words, the function of utility of an object depends on what they call as the assignment of functions. However, aside from its changing physical function, the social meaning of objects also varies through time. This observation was quite evident in how the physical chair found itself having a different utility and social meaning during a pandemic. So in this presentation, I discuss how the chair as a physical object represents social realities in the Philippines, even in a situation like a pandemic. A chair in this regard is taken as a social, cultural material, and its function develops through time. This paper is anchored on symbolic interactionism, and it uses it as a lens in making sense of how objects are given life by humans. As we are probably all familiar with such situations, symbolic interactionism alludes to the idea that people make meanings or attach meanings to objects, depending on how such objects are given a meaning at a specific point in time or in a particular social and spatial context. Can you still hear me?
Yes, yes.
Okay. So my paper is based on how I myself, and how other people see the chair as an object in relation to relief operation in the Philippines during the COVID-19 pandemic. Data for this presentation or for the paper has been called from netizens' Facebook posts relating to the chair or the silya in the local language and to its role in relief goods distribution. I also searched for news articles regarding the use of the chair in relief operations and engaged in some FB chats with people who posted related online materials for clarification and probing. Although quite minimal, I also made reference to my personal experience in receiving assistance during the pandemic. A physical object, according to Apadurai in 2006, has social significance. In fact, he argues in his 1986 essay that the human-object transaction can be mediated by social or people-to-people interactions. In other words, the way a person relates to a physical object can be influenced by the person's relationship with other human beings. Now, drawing on Aparaday's argument, one can say that the chair as a physical entity is given alive through social interactions. While it is expected to provide function, the chair as a physical object becomes more than what it is through social interactions. In fact, RCD and Pontecorvo should not only be seen as a form of adaptation to an existing reality, but also as an extension of social activities.
Yeah, I think we tried. Professor Tudor has kindly offered to give a summary of his presentation. Shall we do that?
If that is the only option available.
I guess so, because of the time.
Yes, I think the presentation he makes is based on certain theory in sociology called symbolic interactionism, where the symbolic significance of objects, physical objects, are explored as to how it influences human behavior. And he looks at the use of the chair in many Philippine houses as the recipient of like relief given by different people. So it seems that a lot of items.
I'm back. I'm not sure if I can be heard.
No, I don't.
Melvin, I was trying to summarize your finding because of the communication problem we have been having.
Yeah. If you can, if Professor Silva is able to do that, you can answer any questions. I think that will work because of the time constraints. Is that okay? Melvin? Yeah, I think you should continue.
Okay. So
perhaps you can reschedule it, I think.
I'm definitely having a connection problem. If it's okay with the organizer, I can just record my presentation and send it tomorrow.
Yes, please
because
do.
at this point, it's really a problem.
Right. Yes, please do. We'll try to get a summary from Professor Silva for the audience. Yeah.
Yeah, the key point he makes in this presentation is that in the Philippines, there was so much of humanitarian assistance given to different people by different agencies, and the symbolic part of it is that chair is used as a vehicle to receive relief, so that the giver doesn't know who will receive his or her relief, nor do the recipient knows who gave it, but it's collected by some organization and distributed to people using the chair as the place to deposit all the relief items. And this was quite big according to Jabba, and that it shows that even during a very difficult situation, people get together in Philippines, and there is a lot of social support mechanisms within the community. I think that's the key point he wants to make, but maybe we can get the full details from his audio presentation, video presentation.
Tomorrow. Thank you so very much for coming in. I think the audience appreciates that. I think the next, so let's thank Jabba, and I'm sure we can thank him tomorrow when we hear the recording, the full presentation. So next would be the break. I think we can cut it short to 10 minutes so that we can start on time the next presentation. So we'll be back in 10 minutes. It's a break time. Thanks again for the participants, for your active discussions. We hope that we will be back in 10 minutes to participate in the rest of the webinar. Thank you.
Was she there before? Julia is there. So we are now on session 7. We have session 7 and 8 to go, short presentations, and I'll be chairing this one, session 7. There are 4 speakers. The first speaker, actually, we have seen Professor Tudor Silva. He chaired some of yesterday's sessions as well and spoke a little while ago to summarize Dr. Melvin Jabbar's work. So this paper is titled Ethnic Variation in COVID-19 Mortality in Sri Lanka, and it will be presented by Professor Tudor Silva. So we will play a recording of it, and then after all of these talks are done, we will take questions after 4 such talks.
This presentation is on ethnic variation in COVID-19 mortality in Sri Lanka. The team involved in the study is given here. Objectives: identify variation in COVID-19 mortality in Sri Lanka by ethnicity and related factors and its change over time. Offer possible explanations for any reported variation. And finally, explore potential long-term social impacts of observed trends. The methodology involved 2 procedures: secondary analysis of COVID-19 mortality data published by the Epidemiological Unit of the Ministry of Health, supplemented by primary data from 2 studies looking at the social aspects of the pandemic, Savadaya study on social determinants, and World Vision Lanka study on humanitarian interventions during the pandemic. This chart gives weekly variation in death count throughout the pandemic from the onset of the pandemic in March 2020 right up to 5th November 2021, the end date for the current study. Pandemic is in Sri Lanka is divided into 3 pandemic waves. The first wave from March to September 2020, and then the second wave from October 2020 to April 2021, and the third wave from April 2021 onwards. As you can see, the mortality was quite low during the first and second waves, but increased sharply during the third wave. This bar chart gives percentage distribution of COVID deaths by ethnicity of the disease compared with population distribution by ethnicity as discovered from 2012 last population census. As you can see, Sinhalese, who comprise 75% of the population, reported about 70% of all COVID deaths. Tamils, who were about 15.3% of the population, reported 13.1% of COVID deaths. And Muslims, 9.5% of the population, reported 13% of all COVID deaths. This database also had information about Burgher community and other communities, but we excluded them from the analysis pursued here. This gives COVID-19 death rate in Sri Lanka per 100,000 population for this entire study period. You can see the highest death rate was reported by Muslims 93 per 100,000, followed by 63.2 among the Sinhalese and 58 among the Tamils. And also we did a test of significance, which found that the difference between Sinhalese and Muslims in regard to COVID death rate, as well as the difference between Tamils and Muslims was statistically significant, whereas the difference between Sinhalese and Tamils were not significant. Possible possible explanations of observed variation: occupational differences among different communities, differences in settlement patterns like urban low-income communities, the Vattas in urban areas, and then Basa communities in suburban areas, and also the labor lines in plantations perhaps also played a role in contributing to this observed difference. And also we looked at differences in religious and social practices like weddings, funerals, and religious behavior, such as daily religious congregations in mosques 5 times a day in the Muslim community perhaps was a significant factor. Fourth, possible variation in compliance with safety measures was also explored. And also we looked at it with any differences in the presence of comorbidities in different population groups. In this chart, we try to break down mortality by ethnicity, gender, and age group. The entire COVID dead population was divided into 6 groups: Sinhala male, Sinhala female, Tamil male, Tamil female, and Muslim male, Muslim female. And each of these communities were further subdivided into 3 age groups. The highest age group between 60 plus, and the middle age group from 30 to 59, and the youngest age group from 0 to 29. As you can see, there is a common pattern of age distribution in mortality in all 6 groups. Highest mortality reported by oldest group, followed by the middle and the younger age group. And obviously this is connected with perhaps comorbidities and other related factors. Here we found 2 important characteristics. With regard to oldest age group, we found that females often reported higher percentage of COVID deaths compared to males. And on the other hand, in the middle age group, which was roughly like the working age group, males often reported higher mortality compared to females in each of the communities. This we found quite significant. We also look at variation in mortality by ethnicity during the 3 pandemic waves. In the first pandemic wave, perhaps the most notable feature is that Muslims, who comprise 9.5% of the population, reported nearly 36% of all COVID deaths. So this was quite significant. In the second pandemic wave, a notable feature was that the Tamil community reported 28% of all COVID deaths. So this was quite disproportionate compared to their population size. And also, perhaps I must report here that the second pandemic wave started in garment factories in selected areas, spread to fish markets. So perhaps there was a kind of higher presence of Tamil community in both these industries. So this is just a speculation. And in the pandemic wave 3, one important observation was that the Sinhala community reported a significant increase in mortality. And this is also associated with the so-called New Year cluster that triggered the pandemic period, 3 New Year period during which there is kind of outdoor shopping, home visits, customary home visits by people. So this may have contributed to this pattern. But on the whole, pandemic wave 3, COVID mortality distribution was largely conformed to population distribution by ethnicity in the population. To summarize our key findings, COVID-19 mortality among the Sinhalese remained lower than their population proportion throughout the pandemic, but they experienced a marked increase in mortality during the devastating third wave. Tamils had relatively low mortality during the first and third waves, but they reported a disproportionately high mortality during the second wave. Muslims reported disproportionately high mortality in the pandemic wave 1, and a notable decline in mortality during the rest of the pandemic, but their mortality levels exceeded their population size throughout the pandemic. Ethnic variation in COVID-19 mortality and by implication infection is not constant as portrayed in stereotypical media and social media posts, which often try to blame certain communities as super spreaders of the disease. During the long-lasting third wave, COVID-19 mortality distribution among communities largely conformed to their population size. To summarize our conclusions from this study, public health interventions reached and penetrated all communities to varying extents. There was vaccine hesitancy in Eastern province at first, but enhanced vaccine uptake in all communities as the pandemic unfolded. In some ways, this change was due to complementary interventions by the state and religious and community leaders who campaigned against misinformation, contributed to reducing excess mortality in the minority groups to a considerable extent by the pandemic wave 3. Removal of mandatory cremation may have also facilitated the enhanced Muslim compliance with public health campaigns, but some social determinants of high infection and high mortality continue to prevail in this community to some extent. Finally, we can end with the positive note. As a public health emergency affecting all communities, the pandemic has increasingly emerged as a common disaster that called for and to a large extent achieved coordinated, unified action from all communities with possible long-term impact on peace and trust building. Thank you.
Thank you very much, Tudor. Please put your questions in Q&A or chat as appropriate. The next presentation is also from Sri Lanka. It's called Demographic and Socioeconomic Impact on Online Consumer Behavior During COVID-19. It will be presented by Harini Jayamaha.
Hello, everyone. I'm Harini from Department of Demography, University of Colombo, Sri Lanka. So I have conducted my research under the topic of demographic and socioeconomic impact on online consumer behavior during COVID-19 pandemic. So this could be identified as my content. So the presentation includes the introduction to the research, the objective of the research, the methodology, the significance of the study, literature review, binary logistic regression, the findings, conclusions, and the references that I have used. First, to start off, I would like to first give a brief introduction about what this study focuses on. So the spread of COVID-19 pandemic made people to change their lifestyles where purchasing goods and services were only limited to online platforms. Hence, the activity or the action of purchasing goods and services or over the internet was given much importance during the pandemic situation. The e-commerce retail revenues indicate that COVID-19 is having a major impact on e-commerce and is expected to cross $6.5 trillion in sales by 2023, emphasizing the positive impact COVID-19 has brought towards the survival of the online markets. Though COVID-19 has positively impacted the online platforms, the purchasing behaviors differ from person to person due to their demographic and socioeconomic backgrounds. Therefore, to survive in the long run, the identification of the demographic and socioeconomic characteristics of the consumers are important. So, as the main objective of this study is focused on to identifying the impact of demographic and socioeconomic impact on online consumer behavior in a pandemic situation, as it will help the online store owners to plan their future accordingly. So from this slide, we could identify the methodology I have used. So as the study area, I have chosen Western province of Sri Lanka as it holds the highest online order share during 2019, according to the statistics of Daras.lk, which is the largest online store within Sri Lanka. And as the sample size, I have taken 600 responses where I was able to collect it by sending 1,000 online questionnaires among people who have internet access. So at a rate of 60%, I was able to collect 600 responses out of all 1,000 questionnaires that I have spread among the community. So as the sampling method, I chose the purposive sampling method, which is a non-random sampling method. And as to collect data, as I said, I have used online questionnaire method. I have distributed the online questionnaires among the people who have internet accesses. And as to analyze the data that I have collected, I have chose the binary logistic regression model as to identify the impact from the demographic and socioeconomic characteristics. So when talking about the significance of the study, many studies have identified the need of infrastructures towards the online markets, the higher computer literacy levels needed by the consumers, and etc. But only few have identified the impact of the demographic and socioeconomic characteristics. Therefore, this study was conducted to identify the demographic and socioeconomic impact towards online consumer behavior during the pandemic situation and to identify whether the results will be useful for the survival of the online markets. So demographic and socioeconomic characteristics such as generations, then gender, level of education, level of income, household types, marital status, employment status, and ethnicity were taken into consideration for this study. So if we look into few literature, so out of the very few researchers conducted to identify the demographic and socioeconomic impact on online consumer behavior within Sri Lanka, Daras.lk's finding states that the highest online consumers during 2019 could be identified between the ages of 18 to 24 within Sri Lanka. And according to Vijay Sundara's findings, Sri Lankan men are more attracted towards online purchases than females. And at the same time, Vijay Sundara identifies the online shoppers within Sri Lanka to be well educated, at least up to the level of advanced level. So if we look into few international researchers, according to Nasseri and Elliott's finding, having a stable income, being married, and having extended families positively impact the online consumer behavior due to reasons such as being able to take financial risks, having two incomes after being married, and having more members while living in an extended family. But according to the findings of Richard, the level of income is not a problem in purchasing online. And according to Thomas, being single rather than married has positively affected being online consumers because of the least number of responsibilities they have. So this emphasizes the consumer differentials that could occur due to the demographic and socioeconomic background within different scenarios or within different geographical backgrounds. So now I have now we have come to the slide where I have explained what is a binary logistic regression model and why I have chosen it to identify the impact from demographic and socioeconomic characteristics towards online consumption. So a binary logistic regression model could be used when the dependent variable includes two responses and predictors being categorical or scale variables with 2 or more categories. In the case of this study, the dependent variables include 2 variables as either yes or no, indicated to be online consumers or non-consumers. Hence, a binary logistic regression has been used in determining the online consumption with the effect of demographic and socioeconomic characteristics. Therefore, in this study, being online consumers and non-consumers have been taken as the dependent variable or the outcome, while generations, gender, marital status, education level, income, household type, and ethnicity has been taken as the independent variables or the predictor variables. So the given table represents the results of the fitted model determining the impact of the demographic and socioeconomic factors on online consumption, where only the variables which were significant in determining online consumption has been presented. So the details in this table will be discussed further from the coming slides. So under the confidence interval of 95%, the statistical significance of each variable has been taken into consideration, where variables such as generations, gender, marital status, employment status, level of education, and household type has been found statistically significant, concluding that that changes in these variables actually impact the population being online consumers, while variables such as Generation X, income, sector, and ethnicity being statistically insignificant, according to concluding that there's no impact on being online consumers due to the changes in those variables. So Generation X was found having no impact compared to the reference category, as both Generation X and baby boomers being least online consumers among the 4 generations. The level of income was also identified to be insignificant, as non-income earners reporting to be among the highest online consumer categories. This could be identified as a result of Generation Z being online consumers, even though they are still dependents. Almost every ethnicity being online consumers without much difference could be identified as a reason for ethnicity to be insignificant and not having an impact. So as per the results driven from the model, the odds of millennials purchasing goods and services are 6.6 times higher than the baby boomers, while it is 11.9 times higher than the baby boomers when considering Generation Z. This trend could be identified by the coefficient values as well. This concludes the probability of younger generations being the online consumers than the older generations. When considering gender, the odds of males purchasing online is 2.4 times higher than the females. The odds of purchasing online is 0.17 times higher when a person is having above secondary level education rather than a person who has below secondary level education. At the same time, the odds of purchasing online are 3.1 times higher when a person is employed than being unemployed. The odds of purchasing online are 3.97 times higher when a person is single rather than being married. Also, the odds of purchasing online are 1.8 times higher when the households are nuclear families than being extended families. Therefore, the model and its results prove that there's a significant impact from most of the demographic and socioeconomic characteristics of a population in determining the online consumer behavior. Though this was done in a pandemic situation, this could be identified in the general scenario as well, which was earlier proven by the literature that I have mentioned. So now I have come to the conclusion of this study. So one may identify different trends and patterns in purchasing online in another geographical area according to their demographic and socioeconomic backgrounds. Hence, identification of demographic and socioeconomic characteristics of the consumers is important, as it will help the store owners in identifying what products needs to be focused the most. As an example, if an area has more aged people, the need of medical services is higher compared to the other areas. This allows the marketers in identifying new areas in expanding their businesses. Also, though online purchases of older generations are visibly lower compared to the younger generations, their online purchases in medical products are proven to be higher in the general context. Therefore, the identification of the demographic and socioeconomic characteristics of the consumers of a given area give rise to several business opportunities while boosting the profits of the survival of the profits and the survival of the online stores of an area in the long run. So as per the responses, the future of the online market was also ensured with 100% response from millennials and next gens in purchasing goods and services online, while even 84% of the non-consumers having decided to purchase online goods and services in the future. Therefore, if one determines in starting an online business in Sri Lanka even after the pandemic, that could be considered as a good idea, as the future of the online market was clearly visible with the younger generations. So nevertheless, the pandemic situation has positively impacted the online markets, but the positive impact could have been doubled if the online marketers had identified the demographic and socioeconomic impact towards the online consumer behavior. Therefore, the study emphasizes the importance in identifying the demographic and socioeconomic factors towards online consumer behavior, proving the theory of recent action, which states the demographic profile of a consumer to be a key factor in determining online consumer behavior. So these are the references that I have used, and I hope you all got an idea how the demographic and socioeconomic factors impact online consumer behavior and how it can be applied in earning profits in a online market. Thank you.
Thank you, Ms. Jayama. We might have some questions for you later. So the third presentation in this session is called Politics 2.0, the pandemic redefining the norms of governance in India. It will be presented by Rajdeep Jha.
Hello and welcome to everyone. The theme of this international webinar is long-term social impacts of the COVID-19 pandemic, and the title of my topic is Politics 2.0, the pandemic redefining the norms of governance in India. This image very clearly depicts what the world is witnessing for the last 2 years. COVID-19, a term, or rather we can say a phenomena, has transformed the temporal and spatial dynamics of the contemporary world and has even redefined the norms of living for generations to come. Moreover, the virus has opened the fragility of human life and exposed how vulnerable and helpless humans could be. There emerged a kind of existential crisis for the entire humankind. The effect of COVID-19 has been overarching and not limited to the health and medical field only. It has engulfed within its ambit all the possible dimensions of human life, be it social, political, economical, psychological, etc. The pivotal theme of this research paper is to capture the metamorphosis which the political space and governance has witnessed owing to the pandemic and its long-term social impact. The COVID-19 has greatly redefined the political landscape and pushed the political agencies and structures to reconfigure and remodel themselves in the light of the crisis. Countries across the globe have been either appreciated or criticized for the way they handle the pandemic. In the last 2 years, the COVID-19 pandemic has become the testing ground for different forms of government, be it democracy and authoritarianism, unitary and federal, or any model in between. Governance become the moot point for discussion. According to the Global State of Democracy Report 2021, more countries than ever, including the established democracies, are suffering from democratic erosion and democratic decline in terms of quality. A negative trend has been that democratically elected governments are using authoritarian tactics, and the pandemic has made it easier to justify their behavior, like politicization of judiciaries, civil and minority right restrictions, media manipulation, and weakening of the civil society. The risk of democratic decline got further aggravated due to the epidemic, and the world witnessed a negative trend marked by the shrinking of the civil and democratic space. Another report which traces the development in democratically backsliding democracies in 20 and 21, India was found to be one of the backsliding countries with most democratic violations during the pandemic, which includes excessive use of force for implementing the COVID-19 regulations, harassment and prosecution of human rights activists and others critical of government policies. Making a literature review relevant to our subject, we find that The State of Exception by Giorgio Agamben brings to the forefront various issues which seem to correlate with the way the pandemic was handled by various governments across the globe. Agamben proposed a general theory of the state of exception, which he claimed had acquired a dominant paradigm of government in the contemporary politics. It was defined as a special condition where the juridical order got actually suspended owing to an emergency or crisis situation threatening the state. In such kind of emergency situation, the sovereign, that is the executive power, prevails over the others, with the basic laws and norms being violated or modified by the state. Secondly, Doug Rudgen and Nikhil Datta in their research paper, Pandemics and Human Rights, Just Security, highlighted how the obvious pandemic response by most of the countries had been imposing severe restrictions on core civic freedoms and very pertinently warned on that the pandemics are fertile breeding grounds for government overreach. Thirdly, Mihir R. Bhatt in the article Impact of COVID-19 on Humanitarian Crisis in India very aptly tried to bring out the result of top-down shutdown exercise of the government and the humanitarian crisis that followed. How did the Indian government respond to the pandemic? Obviously, India being a developing country with a population of 1.3 billion, the fear psychosis was much more intense and alarming. Moreover, the Indian constitution has never envisioned managing a cataclysmic global pandemic like the COVID-19. The prime and foremost question was how to handle the crisis situation. Both the center and the states were in a dilemma as to which provisions of the constitution should be used to handle and contain this crisis. Going by the federal provisions, the 7th schedule of the constitution, which dealt with the distribution of power among different constitutional units, has given primacy to the states vis-a-vis center on the issue of health. In absence of the word disaster in the 7th schedule of the constitution, the union deployed the residuary powers to invoke the law and thereby issuing various directives to the states, with the situation becoming more aggravating. On the other hand, the states invoked the Epidemic Diseases Act 1897 to deal with the epidemic-like situation and used the provision to issue state epidemic diseases COVID-19 2020 regulations to make necessary regulatory provisions for handling the pandemic. The center used the provisions of the Disaster Management Act 2005 and issued necessary guidelines and instructions to the states regarding matters like length of the lockdown, restrictions, and containment zones. A critical analysis revealed that the pandemic brought the full power of the center in display, like imposing the lockdown, monitoring state responses, including physical distancing norms, regulating economic provisions, and even grant of financial packages. This issue became more contentious when the MHA, that is Ministry of Home Affairs, forced the Kerala government to roll back its decision of opening the restaurants based on local assessment and was cited as a peak of centralized federalism. Section 11 of the Disaster Management Act 2005 provision for national plan for containing the pandemic by taking states and other stakeholders into confidence, which was however found lacking, rather absent in this case. With the increase in COVID-19 cases across the world, Prime Minister of India announced a 3-week lockdown on 24th March 2020 to curb the menace of virus. The lockdown was further extended till the first week of June 2020. One of the distinctive features of this lockdown was that it was considered as a top-down exercise, where the Disaster Management Act 2005 was used by the executive to impose lockdown in the entire country. Long-term social impact of COVID-19 could be gauged in terms of sinking of democratic space with the encroachment on the federal structure by unilaterally taking the shutdown decision. In case of India, the diffused federal approach became a moot point for comparison with the centralized and authoritarian system of China. The need for a unified hierarchy for an established response to the crisis has fueled the need for such comparison. Secondly, the pandemic led to a kind of colossal entitlement failure, with the chances of a state completely appropriating the power and turning into a leviathan in the long run. If appropriation of power acquiring a centralist tendency becomes an excuse for handling any crisis, then there are maximum chances of developing a kind of a structure which would be all-encompassing and controlling the minute dynamics of agencies. There are probable chances of the structure agency debate taking a completely new facet as one of the long-term effects of COVID-19. Another probable long-term impact of COVID-19 could be gauged in terms of serious implications for the party system and electoral system. The pandemic might disturb the balance between representation and effectiveness demand and tilt more towards the latter demand. If the state of exception would become the new normal, then probably long-term effect would be change in the nature of party system that is becoming more and more one-dimensional in order to boost the effectiveness demand. Further, there are equal chances of parties manipulating the electoral system in a more unilateral fashion so as to suit their nefarious design. In terms of gains by the political elites, there are evidences which suggested that promising free vaccines during election campaign in one of the provincial legislative elections in 2020, that is of Bihar, gave an electoral edge to the party. This could be testified by the electoral results as the BJP emerged as a larger party in the winning coalition for the first time. Though the BJP was not able to harness the benefit of long protected election in West Bengal, but still managed to increase its numerical tally to a considerable extent. Secondly, the borrowing limits of the states were increased from 3% to 5% by the union government, but only on the terms and conditions fixed by the latter. Thirdly, in the upcoming legislative elections of the 5 provinces due in February-March 2022, the Election Commission of India has made announcement for having no physical rallies going for the polls owing to the Omicron threat. This announcement paved ways which are going to be more digital and virtual. Digital and virtual mode of campaigning would probably change the entire culture of electioneering and electoral politics, and party having more digital connectivity and power would be in a more advantageous position, and presently BJP could be seen as a front runner in this case. To conclude, we can say that the pandemic has greatly redefined the norms of governance in India. It has brought a kind of paradigm shift by altering the thought process. Pandemic provided an opportunity to the union government for greater appropriation of power at the expense of the states, especially during the first wave, and led to mollification of certain issues, giving rise to new conflicts spinning around COVID-19 and electoral politics. Another important point which needs a special mention here is that the pandemic has made the class divide starker, and hence governmental efforts and relief packages should be based on the Rawlsian notion of justice, that is, benefit of the least advantaged, instead of looking from the utilitarian perspective, that is the greatest benefit of the greatest number. In this study, we found that there is a need for more decentralized and responsive mechanism to handle this type of crisis in the future, with different tiers of government working in tandem with each other, giving way for a more cooperative federalism. Also, there should be praxis in the government's maxim for minimum government, maximum governance. So thank you, and stay safe and stay healthy.
Thank you very much. Thank you, Dr. Jha, for that presentation. The final presentation in this session is from Canada on long-term social consequences of COVID-19, the Canadian experience. It will be delivered by Dr. Sarath Chandrasekhar.
Good evening, ladies and gentlemen. Bonsoir, mesdames et messieurs. I am Sarath Chandrasekhar. Now I am going to make my presentation. The title of my presentation is The Long-Term Impact of COVID-19 on Culture and Social Behavior, the Canadian Experience. Let me give you a little bit of contextual factors about Canada. 38 million people living in Canada in 10 provinces and 3 territories. It's a multicultural society with 87 ethnic origins. COVID-19 affected all provinces and territories. 4 provinces were badly affected: the British Columbia, the Alberta, Ontario, and Quebec. The total victims, 3.19 million, and the total number of deaths up to now is 35,439. Culture and social behavior can be understood in terms of beliefs, values, and social interactions, or the practices the people have adopted. I prefer to divide the Canadian population into 2 categories. The old-timers, that includes the Aboriginal people, the British, the French, the Italians, the Ukrainians, the Greeks. Now they are running into the 5th or the 7th generation in Canada now. And the newcomers, that is the second category, that includes the South Asians who came after 1990s, the Middle Eastern people, African groups. They are running into the 3rd or the 4th generation. 80% of the COVID deaths represented Canadian seniors, 65 years and over, in 2020. People in apartments, racialized groups, that's the visible minorities, new immigrants born outside Canada, and spoke no English or French. They were the most vulnerable people in the Canadian society. There's some kind of a social inequality here. And their cultural practices helped spread the virus very fast. Now I'm trying to look at some of the selected indicators of the health restrictions. Social distancing was one. It's not a serious issue for the Canadian-born old-timers because they were in general were not keeping a very close contact with the other people. They will hug somebody only if they know them very well. However, for the immigrants, the newcomers, especially after those who came after 1990, that was a critical issue because they came from a collective culture. COVID-19 spread very fast among them. After 24 months with COVID, the newcomers have got used to some kind of social distancing now, not visiting relatives or friends frequently. Old-timers have become accustomed to interact with other people more frequently. That's another change. In the long run, people would continue to maintain social distance. That's what our prediction is. Wearing masks was another mandatory requirement for the Canadians. Many newcomers, Chinese, Japanese, Koreans, used to wear masks when they are sick, even before the COVID. Majority of Canadians will continue to wear or at least carry a mask in their pocket or in their wallet when they go out. It has become a personal item, essential. A strong belief in mask as a protective measure or a preventive measure is gradually established. Therefore, this habit will continue for many, many years to come. Working from home and unemployment are 2 other important issues. Usually Canadians go out of their homes to work, both husbands and wives, or men and women. Past 24 months, many of them were forced to stay home. Now this new behavior pattern, that is 24/7, everyone together under the same roof, brought back certain old habits such as eating meals together, both breakfast, lunch and dinner, and having family games and fun. However, family violence has also increased during the same period. Husband-wife abuses and yelling and verbal abuses. In the long run, couples will get used to this new normal. Women prefer to work from home. Public servants, bankers, teachers, and other kinds of office workers have been permitted to work from home. In the long run, many people would continue to work from home. Some federal departments have begun to amalgamate several departments or units into one building to save cost. Housing market. People have homes within the Greater Toronto area, sold their homes for an unprecedented price, and went 65 to 75 miles away from Greater Toronto area. You can buy a home for a very cheap price. They can work from home. About 200,000 people lost their jobs. Some did not want to come back to their workplaces, like the seniors' homes, nursing homes, hospitals, and some school teachers. Especially those who got affected by COVID were reluctant to return to their places of work. This has created a heavy employment problem for Canada. So many vacancies have occurred in many years. It might take many years before we fill all of them. In the long run, filling positions will continue to be a problem unless workers are imported from Asian countries. The seniors' homes are another areas worstly affected. In the future, it will be difficult to fill their staff vacancies. More new opportunities are now open for foreign and trained home care workers to come and work in those places. And most of the early deaths, actually about 80% of the deaths, came from these homes. A very high degree of anxiety, depression, and frustration are reported among the surviving seniors. Visitors are not allowed to see them regularly. Now I want to pay attention to the Canadian welfare services. Canada has one of the best welfare services in the world. Pensions, old age security, disability pensions, child tax benefits, maternity and paternity leave, and employment insurance are included in this. These services became highly challenged with new applications. At the same time, lack of staff to handle those applications became a big problem. So that resulted in delays. On top of these, new financial benefits package were introduced, ranging from Canadian $2,000. Now these are not going to continue, these packages are not going to continue. So some people who did not want to go back because of this monthly allowance are in trouble now. Government is now applying taxes on these free benefits. In the long run, I have a feeling that the people will be forced to abandon those free benefits and find jobs on their own. Long-term impact of the overall impact. General feeling of a fear for life and death has set in. Even teenagers, youth, and children are showing symptoms of anxiety and depression. No one is sure of any future developments or whether a new variant of COVID will set in. Several suicides have been reported, even inside universities. Losing beloved family members will continue to have a tremendous negative impact on many people. Some of them could not even see their dead bodies. School-going children were badly affected. No friends to play with, no sports, no other recreational activities, even visiting parks and intermingling with other children. Interrupted education. All of those things had a tremendous impact on their psychosocial development, especially in the age group of 3 to 6 years of age. In the long run, as soon as health restrictions are removed, we are confident that the children will go back to their pre-COVID practices. In the long run, the Canadians will begin to live with long COVID, and it may become an endemic, just like the annual flu. A belief in a new normal is increasingly being accepted. However, nobody knows exactly what that new normal is going to be. Some Canadians continue to fight against the vaccinations, but 89% of the Canadians have got both vaccines. But there's a fair amount of number of people, working people, who have refused to get the vaccinations. People do believe today that COVID pandemic cannot be controlled simply by individual actions. Canada is basically an individualistic country, but now they have begun to realize that individual actions are not going to help this. It has to be a collective effort. This value change brought social harmony among many Canadians. Thank you very much. That's the end of my presentation.
Thank you very much, Dr. Chandrasekhar. It must be quite early for you in Toronto or wherever you are joining us from. So we have, I think, 3 questions. Our second speaker is unable to join us because I think there is a power cut on. So anyway, let's have the questions up on the screen as has been our practice today. I can see anyway, the first question is from Professor Karunavira. It is to the first speaker about was mortality expressed as a percentage of infected individuals in each ethnic group, or was it the total ethnic group? Presumably is the question, right? Tudor, can you respond to that? Mortality.
Thank you, Professor Nadira, for that question. Actually, we are using 2 measures. One is mortality, percentage distribution of mortality among different groups as a percentage of total mortality, not percentage of infections, because the problem with our data is that infections, morbidity is not given in terms of ethnicity in any of the sources available. So we only use the mortality data and compared it with population distribution by ethnicity in the population using 2012 last census. So that is the procedure we followed. And also another measure we used is a rate of COVID mortality per 100,000 population among the 3 different groups. And I presented that data as a rate per 100,000 of the population. And also argued that there was a kind of statistically significant difference among certain groups. So that's the procedure followed.
So maybe a follow-up question is Professor Mathumas, whether the vaccination.
If I can.
Sorry, okay, follow-up question from Nadira. Yes.
Yeah, just to ask, I understand that. That's what I was wondering. Now, after getting the infection, how soon they access healthcare, or when it is, in these different ethnic groups, it would have been very interesting to see, but I fully understand if the data is not available freely, it's not possible. Yeah, that was the reason for that question. Thank you.
Then Professor Madhuma is asking about vaccination rates. Maybe Tudor can answer, but maybe that also was not available, is my suspicion. Do you want to respond?
Yes, that is certainly the case. Vaccination data is also not available according to ethnicity. But we had some anecdotal evidence of vaccination coverage and poor or high uptake of vaccines in certain communities. I think in one of our earlier studies, we found that there was a vaccine hesitancy, particularly in minority communities in Eastern Province. This was, when vaccines were introduced early on. But one of the ways in which they overcame that problem was by mobilizing religious and community leaders. They went around instructing their fellow community members to go for vaccination, and that worked, I think, for the most part.
So if I may just bring Dr. Sarath Chandrasekhar also into this discussion together with Tudor.
Please.
So Tudor's view is that, in the long term especially, there aren't many differences between these different communities. Of course, these are communities that have been in the country for some time. Whereas Sarath is saying that, more recent immigrants into Canada, that there was greater impact of COVID. I'm not sure whether he mentioned mortality. Do you want to? Can I just ask Sarath whether he can respond to Tudor's findings and compare it with the Canadian experience with respect to different ethnic groups? Yes.
Right. Good evening, everybody. It's time 7:20 here in Toronto. Now the comparison between the Tudor's data and the Canadian experience is that most of every year we get about 250,000 new immigrants coming into Canada. Now they are not coming from the old sources. They are coming from new source countries like South Asia, Middle Eastern countries, and then Africa. And they take at least 2 to 5 years before they really give up their old traditional habits and begin to adopt some of the general ways of living in Canada. Now, during that period, so most of these people who got affected by COVID this time, especially during the second year, 2021, most of them were living together, in small apartments, and in one area, maybe 50 families living, buying homes in the same area, places like Brampton, in the western part of Toronto. Now, and also they did not give up their general interaction patterns. They visit everybody every evening and every morning. The weekends they get together and have parties. And some of the boys were playing cricket, and the others were having big thumping weddings. Now, all of those experiences really allowed or helped spread the COVID, in a very big way. And it was not easy for any of the health authorities to intervene at that time. But then the government, as I think Jabbar said, came very harsh on them in certain areas. I think the mortality-wise, the mortality was high among the new immigrant groups and the seniors. The seniors were mostly the old-timers, the parents of the old-timers. And because they were living in one place, like over 100 seniors' homes found in the Greater Toronto area. So the rates were very high among them. So that's what I would say about the mortality.
Okay, thank you. We are running a bit late. So let me just ask a question from the third speaker, that is Dr. Rajdeep Jha. You were talking about erosion of democratic values, which Rahul Mukherjee also was speaking about yesterday. Now, is it likely that, things will return to the previous situation? Or do you think that these changes, would have a permanent effect? Are you there to answer this question?
Yeah, sir, I'm there. Yeah, I'm here.
Yeah. And yeah, okay, that's the question.
Okay, sir. First of all, sir, thank you for giving me this opportunity to present my paper on this platform. And responding to your question, I would like to say that I mentioned in my paper that first lockdown was a kind of unilateral centralization. And then the second one was unilateral decentralization. One of the recent guidelines which came in February, after first of all, the Omicron threat led to again banning and shutdown in different parts of India. But the response of the Indian government, that is the central government, was quite different from the first time lockdown. In this time, that is during the third wave, the government responded in a completely different manner. They tried to cooperate with the states. They have left it on the states how to relax or how to deal with the restrictions things as the Omicron threat is getting slowly down. So, sir, as an academician, my purpose is not to criticize. Our purpose is not to criticize any government or so. It is been done for the last 2 years. The purpose is to how we can handle this kind of pandemic or cataclysmic event in future. So we find that the kind of cooperative federalism slowly and slowly it is getting back, with the states responding positively to the center and center also relying on the states. So slowly and slowly a kind of cooperative federalism is getting started. But there is a point, sir, that if the state of exception, which I have mentioned in my paper, it would become the new normal, then it would have a crushing effect not only for the federal structure, but even for the democratic setup, be it elections, be it party system, be it anything, be it any political agencies. So my response for this is that yeah, it is getting slowly and slowly, the things are getting better, but we have to be cautious and we should not be like that. Okay, now it's getting normal, so like that, as it is getting normal, so things should be taken in a very cautious way, sir.
Okay, thank you very much. Right. So that brings us to the end of this session.
Sir, I have a question for Bharat, sir.
Okay.
Yeah. Yes, sir. Just a minute. Actually, sir, I was reading in the newspaper, and in the news I saw that the Canadian Civil Liberties Association has initiated a legal proceedings against PM Justin Trudeau government over its decision to invoke the Emergencies Act following mass protests against mandatory vaccinations. The same state of exception by Giorgio Agamben, which I mentioned in my paper, and we find that the same state of exception found resonance with the action which was taken by Trudeau. He invoked the Emergencies Act for the first time in 50 years to give the federal government extra powers to handle the ongoing truckers' blockades and protest against the COVID-19 restrictions. So what is your stake, sir, on this?
Yeah, now this was very recent, I would say about 72 hours ago. It was proposed, the Emergency Act. Now, the main reason behind that was about 200 people who were driving trucks, who are transporting goods from Canada to United States and back. They blocked the main highway, the American border, not in one place, about 4 places. Now, as a result, the general population had a tremendous impact because they were not getting enough food. Most of the things, go back and forth, vegetables, fruits. Now, so they were kindly asked to have the demonstration limit to about 2-3 days, but it lasted for over 2.5 months. Now, at that time, I think the Prime Minister was forced to adopt this new regulation, which has not happened for the last, I would say, 30-40 years. Yeah, that was discussed in the Parliament, and all parties, the NDP, the Conservative, Progressive Conservative Party and the Liberal Party, all 3 parties supported this move. However, in reality, nothing has happened. It is there as a kind of a threat. And therefore, some people are going to courts against that. Is it illegal, unethical to impose a condition like that? The thing is, at the same time, there's another counter measure from the people who are affected by this scarcity of food and the freedom, especially people in downtown Ottawa, where the Parliament building is. The people could not move in and out because of these truckers. So they are organizing themselves and applying pressure from the Prime Minister to have strict control over the situation. What I see now, yesterday, last night, the Ottawa situation has been resolved because the truckers they have started going out. And most of these people are not from Ontario, they are from other provinces. And also there is another allegation that some of these truckers are racist group of people, the white supremacists, and they are trying to bring disrepute to the government, which is in power. And they have been supported by the Progress Conservative Party of Canada. That is another side of the story. So the situation is, to a great extent, is resolved. But my personal feeling is I don't think he's going to impose any of those conditions. About 200 people have been arrested, people who were on the convoy, the blockade, and there will be court hearings. And eventually, going by the previous experience, most probably, they will be released with a small fine. That's what would happen.
Thank you very much. We have to bring this session to a close and start the
Thank
next
you.
one. So thank you for your participation and thank you for responding to those questions. At this point, I think I'm going to hand over chairing the session to Professor Tudor Silva, who was a speaker in the earlier session, but he is a sociologist and probably better able to handle this session than I am. In this session, there are only 3 presentations. The first one that is listed in the program is not available. So I will hand over to Tudor to introduce the next 3. And the presentations will be, the recorded ones will be played. Over to you, Tudor. Thank you.
Thank you, Professor Dias. Yes, in this session, we have 3 presentations, and I will go according to the agenda. The first presentation will be by Samarasekara and Gunawardana. The title is Identification of the Impact of Flood Disaster Risk During COVID-19 Pandemic, a case study in Kelaniya Divisional Secretary area. This is interesting because COVID-19 is not the only disaster that we are dealing with. We are dealing with multiple disasters. So that is perhaps an important aspect of this presentation. It's over to this team.
Hello everyone, I am Sairu Gunadana from Faculty of Engineering, University of Sri Jayawardena, and I am going to present you about the assessment of flood risk management during COVID-19, a case study in Kelaniya DS Division. This is the content of my presentation. When talk about natural hazards, droughts, floods, landslides, cyclones, vector-borne epidemics, and coastal erosion are the most frequent natural hazards in Sri Lanka. According to the United Nations Disaster Risk Reduction, when we consider the occurrence of disaster percentages from 1990 to 2018, 58% of total disasters are flooding. And when we talk about the impact of COVID-19, as you all know, COVID-19 virus has become a critical pandemic today. Until now, there are more than 620,000 confirmed cases and 15,000 deaths because of the COVID-19 outbreak. When we talk the global-wide situation, the impact of monsoon rain compound the effects and risks of COVID-19 and increase the chances of transmission in Bangladesh. So it is better to focus about an overlap situation of the COVID-19 and the most frequent water-related disaster in the Sri Lankan context as well. So this work may be useful in order to identify the potential weakness in the policies. This is the flow of my literature. The findings are flood is the most common water-related disaster in Sri Lanka. Local organizations and communities are significant considering flood disasters during the COVID-19. Preparedness and response policies for a flood disaster should be updated considering the COVID-19 health guidelines. Sri Lanka needs a policy framework considering the multi-hazards and improving the collaboration between disaster management and health authorities. And the research gap is how to do prepare and response for a flood disaster during the COVID-19 pandemic in Sri Lanka. When talk about research program and aim, as I mentioned earlier also, flooding is the most frequent water-related disaster and the challenging thing is to evacuate under the COVID-19 health guidelines. So the research problem is how to prepare and respond for a flood disaster during the COVID-19 pandemic. The aim of this work is to identify the challenges of a flood disaster during the COVID-19 pandemic and to propose solutions to overcome those challenges. The focused area in this work is the Kalani area, which is located in the lower reach of Kalani River Basin. And this picture shows the floodplain of Kalani River Basin. And this shows the flood extent for Kalani River Basin and its surrounding. And this numerical data shows the flood inundation for lower reach of Kalani River, and there is a considerable amount of inundated area and for flood depths of more than 5 and between 3 and 5 for return periods of 10 years, 20 years, and 30 years. So when we look at about the flood and COVID-19 risk, In a risk, there are three components. Those are hazard, vulnerability, and lack of preparedness. So when considering individual of those components, lack of preparedness is the most practical component to handle. So the focus area of this work is the preparedness component. When we consider about the deaths according to the age groups, for people more than 60 years old, there are death percentage of 76.24 from the all death percentages, and that is the most vulnerable group according to this data. So the high risk group is the elderly group. In Kalani area also, the most vulnerable group, when we consider that, there is a 47.75 of age amount of people who are more than 60 years of age. 60 years of age. So there's a considerable amount of vulnerable group considering COVID-19 in this area. So we have to pay special attention for those people when we give the recommendations. In this work, I use DBSIR framework, and the drivers, pressure, status, impact, and responses are the component of this work. And the drivers, pressure, status are found by interviews with the government officers, and impacts and responses are done by report analysis, literature review flow, and also with the ideas of those government officers in this related to this field. The interviews are done in semi-structured interviews, and the government officers are disaster relief service officer in Canadian Division and Secretary Office, assistant director of district disaster management center, and officer in National Operations Center for Prevention of COVID-19 outbreak. So according to those interviews, the drivers found are spread of new variants, frequent floods in the area, economic crisis, number of flood victims, because that get higher because of those illegal settlements in the area, and lack of researchers. When talk about this lack of researchers, although there are researchers about dual risk, this case is sensitive according to the socio-economic conditions and environmental conditions. So that also the lack of researchers is also a factor for drivers. The pressure factors are elderly population is high, illegal sand mining and gem mining. Conflicts could arise between victims and officials when implementation of policies, and camps do not have enough space to keep social distance. And for the evacuation centers, it is difficult to get permission from those people who own those places, because according to the COVID-19 guidelines, we have to maintain the social distance, and so to do that, we have to find places with some big space. So finding those kind of places are not that much easy to do. And the other factor is the people's awareness is not enough to deal with this kind of situation, because this is a new thing for those people. And the statuses are number of evacuation centers has been increased. Village vulnerable organizations are prepared, because in a flood situation, the people who are there in those villages have much good idea about the situation. So preparing those voluntary organization is important. And checking the fever of people before getting them into the evacuation centers is another thing. And each family should have a disaster bag with their medical documents, prescription drugs, and other important things in a which need to be in a evacuation center. And also 64% 64.5% of the total population has been fully vaccinated, and other factors viewing the urban drainage plans for improvement of the drainage systems. The impacts are subsequent mutations may make current vaccines less effective. Locals are often not properly receiving the warning messages. Most potentially contagious peoples cannot be detected by temperature monitoring, enabling to mobilize people to raise awareness, and the rapid urbanization to invade areas that were not previously considered for flood defenses. From considering all of these, the responses are promote community activities such as hygiene, promotion, and early warning, inform through programs from television, radio, and social media, because we can't gather people in this kind of situation. And starting a new housing scheme project plan, move those people who living in those invade areas to those housing scheme project, those houses, and also proposing new economic centers and preparation and implementation of a new flood management plan, create community leaders vaccinated with booster dose, define the roles and responsibilities of all technical agencies, improve early warning and dissemination mechanisms. When we talk about the role of governing parties, those are making necessary changes in ordinance related to disaster management, ensure the safety of health authorities and the disaster management staff, implementation of a new flood management plan, strengthen the implementation of relief mechanism, direct the people living in lowland areas to new houses, and governing officials also should guide and support government to make necessary changes and law and ordinances. That is about my presentation, and these are the references. Thank you. If you have any questions, you are welcome to ask them.
Thank you very much. Yes, if you do have any questions, please ask it in Q&A chat, or even you can raise your hand. I think the good thing about this presentation is it brings in the environmental dimension, which was also stressed by one of our keynote speakers right at the beginning. Let's quickly move to the next presentation. It will be by Pereira, Vijayanayaka, and Vitanachi. The title is Impact of COVID-19 Pandemic Crisis on Employees' Psychological Well-Being, a Systematic Literature Review. It's over to the next presentation.
Good afternoon. I'm going to present the research on the topic Impact of Workplace Burdens due to COVID-19 pandemic on employees' performance in apparel industry, Sri Lanka. Collaboration work of myself, L.D.L. Pereira, Professor A. Vijayanayaka, Dr. A. Vithanarachi. This is the outline of my presentation. Let's move to the introduction. Apparel industry is one of the main export revenue generator in Sri Lankan economy. It contributes 44% to national exports, employs 40% of the active labor force in the country. Also, Sri Lankan Export Development Board is expecting $8 billion export income in 2025 from the apparel industry. As we all know, from 2019 onwards, we are suffering from the COVID-19 pandemic, which has resulted 673,000 infection cases, including 15,994 deaths in Sri Lanka only. When talk about the workplace burden, it's the emotions such as concern, anxiety, uneasiness, and depression felt by workers due to success or failure of the work, safety, workload, and working condition. Let's move to the problem identification. COVID-19 has impacted not only the human health, but also the world's economy as well as the employees' health. To cope with the economic crisis, employees' salaries and bonus payments has decreased. Some has lost their jobs. Also, due to healthcare restrictions, employees' working modes has changed. Some were restricted to working from home situations, while some had to go to work with the great infection risk. Also, second wave of COVID-19 infection was developed around an apparel company in Western Province, Sri Lanka. With all the circumstances happen, it has caused employees to have less job satisfaction, lack of concentration, and high absenteeism, ultimately causing the less productivity in the apparel industry. Let's move to the literature review. The selected literature is Employee Stress Level Assessment, a case of apparel industry in Indian garment sector. Their aims and objectives of the study is to use a multi-case fuzzy approach to measure employee stress level in apparel industry. And in their methodology, their research approach was quantitative. Sample was machine operating employees in Indian garment industry. Data collection methods was questionnaire surveys. Data analyzing method was multi-case fuzzy methodology. Their outcome and findings were less adaptability to change, job-induced individual working capacity, environmental, economics, and ambience has a positive impact on employee psychological burden. Through the thorough literature review, identified the research gap that only a few studies has investigated workplace burden of apparel industry employees in the pandemic crisis in Sri Lankan sector. Among them, a very few studies has focused on the impact of employee performance. This study is conducted to identify the factors affecting employee workplace burden in the times of COVID-19 and guide human resource department and relevant policymakers to develop right set of strategies to mitigate the bad outcome of employees' health and performance. This study was methodically carried out with the steps as mentioned. Initially, systematic review of literature, then take the input from industry experts and identify the factors affecting psychological burden and performance measures, then develop the conceptual framework, develop the survey, collect the data, and evaluate the factors affecting psychological burden and performance, finally revising and finalizing the conceptual framework. After doing the initial literature review, identified 6 different factors affecting employees' workplace burden which was mentioned more than in 5 studies. And as performance measures, trait-based, behavior-based, and results-based performance measures were selected. And after the literature review, the findings were subjected to evaluate of the industry expert opinion. Then the experts were selected from the apparel industry who were having more than 5 years experience in different levels and working modes. 10 industry experts opinions were considered, 5 from MAS, 3 from Hella Clothing, and 2 from Brandix. Considering the similarity among the factors and the industry experts opinion, final conceptual framework was developed. As the final conceptual frameworks, as the factors affecting workplace burden, and as the independent factors, exposure to COVID-19 and the workplace preparation, job-related uncertain future, workload and work-life conflict, work-related relationships are selected. As the dependent and the performance factors, trait-based, behavior-based, results-based factors were selected. A questionnaire survey was developed to evaluate the initial conceptual framework. The population was employees in apparel manufacturing industry Sri Lanka. Sample was employees in selected apparel manufacturing companies, Western Province Sri Lanka. MAS, Brandix, Hella Clothing accounting 70% of the population. Sample techniques was random sampling. Data gathering techniques were online questionnaire distributed in Sinhala and English languages, and data analyzing tools were SPSS, PLS, SCM. The initial number of responses 84 number of responses were able to gather, and after the preliminary data analyzing, 79 responses were carried out for further analyzing. So as the initial preliminary analyzing, it was done using the SPSS software. Initially, visual inspections were done, and Cook's distance analyzing, skewness and Kudra's analyzing was done, and then it was used the PLSS software for further data analyzing. Internal consistent reliability, factor loading were evaluated. As per the left side table, it shows the p-values among the independent and dependent variables with R-square 0.25 and significant value 0.5%. According to that, the final framework was developed in the right-hand side. According to the findings, job creators uncertainty in the future has no significant impact of employee performance in a country like Sri Lanka. Compared to the other countries, it has more job security for the employees from the government and also from the employee side. And exposure to COVID-19 and workplace preparations has a positive impact on employee performance, claiming that policymakers should more focus on the workplace health aspect, which they are considering more, which they need to consider more. Then as the workplace relationship developments, also it need to be focused more regarding the work related relationships. It should be focused more from the policymakers and HR department side, because it has a positive impact on trait-based, behavior-based and results-based performance, which indicating that the policymakers should more focus on the work-related relationships, because in the early pandemic situation compared to the pandemic situation, current situation, apparel industry workers were more engaged with each other in every activity. When considered the workload and the work-life conflict, it has a negative significant impact on behavior-based and results-based performance, which indicating the efficiency of the employers are higher with the load of work, which is a important finding. And through the open-ended question areas, below suggestions were identified as the most mentioned factors in factors releasing employee workplace burden in this COVID-19 situation. As the factors reducing the COVID-19 virus infection burden, creating roster plans and strictly following up, strictly work from home for whom is eligible, and providing incentives for those who follow health habits, and a deduction from the salaries from those who are not. And as the factors reducing the job-related uncertainty person as the suggestions, response faster to the changes in the market, reduce the salary would be bearable to protect the jobs of everyone, which is an important factor, provide letters stating the job security, clear communication on the business situation. Then as the factors reducing the workload related burden, being efficient generating in the working hours, approaching the expected outcome without going for overtime working and working on weekends, understand workers' potential through a personal survey and providing flexible working hours, reducing as the factors reducing burden related to workspace relationship. Immediate management is required to pay close attention to employees under having team bonding sessions online, introducing suitable communication methods, and through the ultimate, this is the survey questionnaire used, and through the ultimate findings, it indicates the importance of immediate actions need to be taken by apparel sector, HR department and policymakers to reduce employees' workplace burden and increase employee performance. That's the end of my presentation. These are the references, and thank you.
Thank you very much. This was a useful presentation because it brought in the issue of industries, and we knew that especially in pandemic wave 2, apparel industry played a significant role in triggering the pandemic wave 2. Obviously, in this study, the focus was on worker, satisfaction and psychological impact. So we will come back to this during the discussion time. Now we come to the last, but not the least important presentation for this evening, and it is on gender perspectives of COVID-19. Will be presented by Seema Agrawal. I think this is a very important dimension which we did not cover in any of the previous presentations. So it is over to Seema Agrawal's presentation.
Namaskar everyone. I am Dr. Seema Agrawal, Assistant Professor, Central Sanskrit University, Jaipur, Rajasthan, India. My topic is gender perspectives relating to COVID-19 in India. I have written on the theme Culture and Human Behavior. Title of the paper, Gender Perspective Relating to COVID-19 in India. And I have taken context, approach, methodology, and conclusion in my abstract. Women tend to be the backbone of society during crisis, even as they are also more likely to face the disproportionate impacts of any crisis. Women are always more deeply and worst affected by any disaster, epidemic, and they become more vulnerable or deprived. The COVID-19 pandemic is no different. COVID-19 pandemic has severely aggravated existing gender barriers, widened India's gender gap in the workforce, and affected caregivers and frontline female workers. The present paper explains gender inequalities in the context of the global pandemic COVID-19. This paper reviews the deeper social, political, economic, and patriarchal impacts caused by and during the global pandemic. The present paper makes it clear that men were more affected than women by the immediate effects of COVID-19. Both the rate of infection and the death rate due to infection were seen more in men, but the longer and deeper effects of the pandemic will be on women, which have been researched in the paper. This paper deeply reviews the deeper long-term gender effects. Approach. The paper reviews the widespread economic social impacts on women on the basis of domestic violence, increased unpaid work, unemployment and wage cuts, gender pay gaps, loss of jobs, and increased responsibilities of cleaning and care-related works. The focus is on analyzing the long-term impacts like bad effects on women's health and mental well-being due to reduced reproductive rights, less access to contraceptives and other family planning solutions, unwanted pregnancies, increased maternal mortality, non-availability of high-quality care, depletion of savings and assets and online education facilities, pandemic-related widowhood. The present paper sheds light on the gender disparity in context of women during and after the pandemic, as well as the difficulties faced by them due to increased responsibilities of care-related works. Care-related options were inadequate even before the global pandemic, but women are at risk of being left behind due to the burden of pandemic responsibilities. Methodology. The study is purely qualitative in nature and attempts to throw light on the impacts of COVID-19 on women. Data analysis on the basis of Google Form surveys. I have given the link for the Google Form survey. Interviews and other secondary resources was conducted to understand various visible and less visible, immediate and long-term effects on women. The research tool used for analyzing the data was a must from different sources for this study is content analysis, and the research method is descriptive research. This study makes use of the secondary sources of data used for journals, working papers, search engines, scholarly articles, research papers, and other secondary. Now we come to the paper. Many constitutional provisions for women. After many legal provisions and acts for women, welfare plans for women, national and international convention for women, national state commission for women in India. But the more things change, the more they stay same. Is true for women. Still they are facing gender inequalities. The reality is that women are still denied basic facilities. Is in most societies, women do not get the benefits of health, nutrition, and higher education opportunities as men. Even today, the patriarchal system prevails in the society in which male domination takes place. Even if women contribute financially to the main and maintenance of the family, there is no ownership of the family. Men often stay away from home. In this way, working women have to put more emphasis on the care of children. What is the reason of these inequalities? We have to understand the difference between natural inequality and social inequality. Sex is a biological term. It is related to natural inequalities like age, color, health, reproductive system, which are not alterable. But the gender is a sociological term which is related to social and cultural inequalities, which is related to inequalities of your status, wealth, power, prestige, opportunity, which is the result of our social arrangement, which are alterable and should be alterable. We can see gender inequalities in masculinity and femininity forms of our society. And worst thing is that women-related matters are personal, not public, that should not be discussed. Now we come to immediate and long-term impacts of COVID-19 on women. If we talk about the global pandemic COVID-19, then men are more affected than women due to the immediate effects of COVID-19. But the long-term effects of COVID-19 are more likely to happen on women. This pseudo pandemic can be seen in a spike in domestic violence as girls and women are sheltering in place with their abusers. The loss of employment for women who hold the majority of insecure, informal, and lower paying jobs. The risk shouldered by the world's nurses who are predominantly women. The rapid increase in unpaid care work that girls and women mostly provide already. Based on the analysis of various data, it is found that during the global pandemic, domestic violence cases increased by 2 to 3 times all over the world. At the same time, their reproductive rights and availability of health facilities were greatly reduced. During the epidemic, the unpaid work of women has increased due to the increase in special care-related works of family and children. Care options were inadequate even before the global pandemic, but women are more likely to be left behind due to these increased responsibilities after the pandemic. We can see here the impacts, immediate impacts. Long-term impacts of COVID-19, generally the worst and deepest impacts of any disaster are on women. The spread of unemployment and wage cuts, gender pay gaps, loss of jobs are more for women due to this epidemic. According to a UN policy brief on the impacts of COVID-19 on women, across the globe, women earn less, save less, hold less secure jobs, are more likely to be employed in the informal sector. Their capacity to absorb economic shocks and therefore less than that of men. The COVID-19 pandemic is clearly aggravating economic inequalities faced by women. We can see here medical facilities, men have more, women less, expensive treatment, men have more, women less, nutrition, men have more, women less, health awareness, men have more, women less, but is still affected by COVID-19, men are more, women less, frontline health workers, men less, women more. Invisible or less visible deeper impacts of COVID-19. Dalvo conducted one of the largest studies of the socio-economic impacts of COVID-19. India's unemployment surge has disproportionately befallen women. Women's labor force participation has fallen to 11%. Loss in incomes for women as well as their household led to reduction in food supply. India also faces a digital gender divide. Only 21% of women use the internet. Very few women have a computer or laptop to do their work from home. There is a very long-term effect on girls' education because they are not having access to online education. Women's health indicators are deteriorated because they could no longer afford contraceptives and menstrual products. COVID-19 has unabated years of progress on women's unpaid care work. Indian women already do almost 3 times more unpaid work than Indian men, and the survey showed us 47 increase in unpaid labor of women. We can see here what are the effects. We can see here what are the effects before pandemic COVID-19. Access to contraceptive less, but during pandemic very less. Result: unwanted pregnancies, abortions. Access to sanitary waste very less. Access to reproductive rights very less. Domestic violence, increased responsibilities, sanitation and cleanliness. Conclusion: Antonio Guterres, the UN Secretary General, requested governments to put women and girls at the center of their efforts to recover from COVID-19. At every level of government, gender-specific data on COVID-19's impacts must be collected. This will ensure the development of sound policies that address women's needs. Focus on the inclusion of single, diverse, separated women in the One Nation, One Ration Card rollout, and will social assistance program for informal workers, specifically domestic workers and casual laborers. A robust safety net is necessary. According to a survey, 1 in 3 women said the government welfare schemes and SHGs had played an important role in helping them navigate the pandemic. Thus, there is a need for universalizing, deepening, and extending the government schemes and SHGs setups in order to help every woman come out of ill impacts from the pandemic as soon as possible. Making the right investment in women's issues now could prove transformational in the long-term recovery and health of our economy and society. And there should be a change in unpaid leave policy so that women can take care of enhanced household work and family. For mitigating any gender impacts of any crisis, there should be an increase in caregiving facilities, qualitative changes in policies, incentive packages, modified schedules, on-site childcare, market-based solutions. Conclusion: you can see our policymakers attentive to these inequalities. There should be more women in decision making. Thank you very much.
Thank you, Seema. I think we have had 3 interesting presentations, and we have some time for discussion. I will start off by asking a few general questions, and I don't see any questions either in Q&A or in the chat box. I think Seema is with us, right? You have joined us now. Maybe I will start with you, Seema. You mentioned, I'm just asking questions about the empirical evidence that you presented. You mentioned that you use a Google survey, right? But we didn't see much evidence from that Google survey. And my question is, you also mentioned about the digital divide in society, particularly affecting women. So in that context, how reliable and valid would be results of online survey?
Thank you, sir. First of all, I must thank to organizers to giving me this opportunity. And I also want to congratulate NASSL for organizing such a nice webinar and very much organized way. Thank you. And I have taken many scholarly articles, ResearchGate and other internet methodologies, and I have taken Google Form survey. Almost 200 working women have filled that Google Form, and I found that data. And I have also my own experience that we are having less access to digital technology instruments. Is still our care related. Am I audible?
Yes, you are.
Okay.
Yeah.
And enhanced care related responsibilities, in my own experience, I was facing them. And my colleagues are facing these care related enhanced care related responsibilities, and this is very hard to manage both.
Yes, that's thanks for that response. Actually, the reason why I asked this question is that during the pandemic, the whole subject of possible methodologies to be deployed in social research during the pandemic came up, because you can't go and talk to people because of social distance issues. So some donors actually refused to give funding for social research, partly because of this challenge. And many people switched to online methodologies for data collection. So from that perspective, the whole methodology of social research probably need to be revisited. I also have a question from the second presenters who work on the women workers in apparel industry. I guess similar. I think they also referred to an online survey in their presentation, but I didn't see a lot of data from that online survey. So I want to know whether how easy was it to apply it in the garment apparel industry, because we know many workers come from fairly low socioeconomic backgrounds, maybe with no access to computers. So in that context, how can Mr. Gunawardana, can you tell us how you use this Google form in your study? Are you with us?
Yes, I mean, can you hear me?
Yes, we can.
Yes. I didn't use Google Form. Actually, I did the interview in a physical way, the semi-structured interviews with 3 government officers. And from those interviews, I used DPSI framework, and for finding the factors for drivers, pressures, and status, I used those interviews, and for finding the impacts and responses, I used literature and report analysis. And from those things, I did my work.
Okay, thank you. So this is actually a sector of the workforce who could not work from home. As we discussed in the previous presentation, they had to come and report, and that is one reason why the apparel industry, I think, played a fairly significant role during the pandemic. I think, Saad, you have a couple of comments, right? Could you ask them?
Are you talking to me?
Yeah, you mentioned that I think you send a message saying that you have some comments on two papers.
Oh yeah, that's right. Now this is particularly pertaining to the second and the third speaker. They both were mentioning the factor of gender, especially how the COVID is affecting women. I have similar experience in Canada. Now, most of the women, especially the new immigrants, I mentioned that earlier, they were the ones who were affected very badly. Most of these women are working in informal employment situations like coffee shops, the McDonald's, the restaurants, the fast food centers, and some of them are in senior care homes. Now, initially they were affected too because they had to deal with the general public, one-on-one, in person, and also the people who could not go out. So they began to start using the drive-through facility to order whatever they wanted. Now, even through that, there was an interaction between the two human beings. So the COVID got spread. Now, what happened was that gradually, when the workers started suffering from COVID, they refused to come back to work. They stayed home, and the 14 days quarantine initially, and then it became 5 days. But then what the employers did was they increased the daily wages from $14.50 went up to $18, especially in the case of McDonald's. They increased the daily wage, the hourly wage for these women, but still they could not get enough people to come back. So you could see that, how it is working in different settings. So that's one of the comments I wanted to make here.
Thank you, Sarat. And that's almost like a market-based approach to responding to the problem. No, like because if people come to work, they are taking additional risk of getting infected, so they have to be compensated for that. So maybe that's an important point. Do the presenters have any comments on what Dr. Chandrasekhar said? Either Gunawardena or Seema? You don't. I have one comment about the first presentation on the flood disaster and its kind of interface with the COVID-19 pandemic. So it looks like, at least in Kelaniya DS division, they already had a disaster response mechanism before the onset of the pandemic, and they used that same mechanism to address flood as well as COVID-19 pandemic. What I want to know from that research group is, how did it work? I mean, because pandemic is a kind of different situation, not a normal, what you might call a normal disaster. And also, issues of people being exposed to floods and, having to respond to the flood, in some ways disregarding COVID-19 guidelines, such as social distancing. So I want to check with you about those issues. Is anybody from that group there?
Yes, sir.
Yes.
So mainly the issues are, as you also mentioned, not as previous situations. In a flood situations, we have to pay special attention because of the COVID-19, because we can't put people in evacuation centers as put earlier, because we have to maintain the health guidelines. So to do those things and other health, the main things, the policies have, we have to change some policies. In evacuation centers also, we have to find places which need more spaces. And also one key thing is the people's awareness. So people don't have much idea about how to deal with this kind of situations earlier. So because they don't have such experience. And also to train them, the government officials can't gather them or do training programs to improve their awareness. So there's that kind of problems, and so as a solution for that, we think that we can inform people through programs from social media, so television, so like that. And also we have to promote the community activities such as hygiene promotions And also one thing is, yes, there is a early warning system in the area, but sometimes this message not getting for people in a smooth way. So we have to improve that also to make a better way to in responding. So, and also in technical agencies, we have to define the roles and responsibilities of all the technical agencies members about their specific roles. So in that kind of situation, there will be no that will not get confused. So those are the things which those are some things which I look in my work.
Thank you very much. We still have a little time left for this session. In terms of trying to summarize some of the key points from session 7 and session 8, primary focus was on cultural drivers of the pandemic and how, different people's practices, like what Dr. Chandrasekhar said about new migrants to Canada and how they responded to the pandemic is quite different from all timers in Canada. So obviously culture played an important role. And also early on, we discussed the role of religion, both as in some ways as a trigger for the pandemic, but also as a resource, as Emma mentioned, as a resource that people use in responding to the pandemic became quite important. And in terms of assessing long-term impacts of long-term social and cultural impacts of the pandemic, I think we have to explore this further. There's much more to do research on. There is also need to synthesize information already available from different countries, because this will help us not only in terms of understanding people's response to this terrible pandemic, but also how we can perhaps deal with a similar problem or maybe a reappearance of a pandemic of this nature in future. So this in some ways relate to the key theme of this webinar. So on behalf of our organization, let me thank all the panelists, presenters for sharing their research results with us, and hopefully you will join us again tomorrow for the final session. So with that, I will hand it over to Professor Priyandas for the final.
Thank you, Tudor, for sharing it. Excellent. Certainly, I think you brought out all the important dimensions of the different presentations with respect to culture. Actually, one question I have, maybe people can think about it, is whether we will become a more distant society, like maintaining the social distance, wearing masks, not shaking hands, whether that will become part of almost a global culture. But I don't know. I mean, some cultures are closer than others. Like maybe Sarath was talking about some cultures that tend to hug people more and things like that. Whether then we will become more distant and what that will do to the quality of our relationships is a question that probably we cannot answer, but maybe we can think about. Anyway, thank you everyone who presented. Thank you, Tudor, for sharing. Tomorrow also is very important. We have a very important education segment. There are many papers on education. It will be chaired by Dr. Ranjit Mahindapala, our immediate past president. And also we have a very interesting paper on foresight analysis from a medical perspective. And there are some other papers on science and health also. So we look forward to seeing you tomorrow, starting at the same time. Thank you for being with us. I'll say good night. Bye. Okay. Thank you.